everyone, and welcome to today's stream. Sorry for the Wi-Fi scuff. But yes, today we will be studying for my general surgery quiz. Alright? Thank you guys so much for being here. Hello to Yui, hello to Nature, and hello to Ghost. How are you guys doing today? I have to prepare for everything, so if you guys want to see me write down like summaries by which I can use to study, I might just enable like the cutscene thing so we can all like see it together. Alright, so let's just open this notepad, because I'd rather not risk showing like my real name, which would low-key be scary. So, you know, yes, we'll type down the summaries and we're going to continue, alright? I hope you guys are having like the best day ever. And I'm so thankful that you're here just listening to me yap about surgery. If you guys have a question, feel free to ask, but I'm not really the best at what I do. I'm just a student, alright? Okay, so let's start with liver masses that are benign, alright? So first case scenario is... Hold on, so this one is gonna be, I think, amoebic abscess. Benign liver masses. So you guys are just gonna hear me type in my keyboard. If you guys want to chat, you guys are welcome to, but you're gonna see me in my medical mood, okay? So we have benign liver masses. Usually when you see a liver mass, you suspect it would be malignant, right? But from the history that you take, you rule out if it's malignant or benign. Malignant is bad, benign is good, okay? So, in this case, 24-year-old male presents with right hypochondrial pain. He gives history of dysentery 1 week ago. He traveled to a Southeast Asian country 2 weeks ago. Oh my god, I'm glad! Okay, so you guys, does anyone know what dysentery means? Does anyone know? I doubt you guys do, but it's okay if you don't. So, basically, dysentery is bloody diarrhea. That's literally it. It's literally bloody diarrhea. Like, it's diarrhea with like blood in it, okay? So, diarrhea with blood in it. Or like mucus. When we examined the patient with an ultrasound, it had a double wall sign. Double wall sign, an ultrasound, with round cystic lesion. Masses in the liver are usually like painless, except if they're inflammatory. And that's when the patient just decides to complain. I'm sorry, you guys are just gonna hear me geek out, okay? But yes, I hope you guys are enjoying like the music. Let me know if you guys want to hear it somewhere. Something to avoid then. Well, you should be kind of careful. I'm sorry guys, my Wi-Fi's been really scuffed. It's like getting better and worse. It's very intermittent. I think it's related to my PC, which is why I have to get it fixed. It's because of the encoder. My video encoder is very hard. Thank you, Galivar. So you guys, after that we did a CT results. Oh my god. But yeah, we basically had a lesion with a rim enhancing wall. Like, you just did a CT scan. If you guys don't know what a CT scan is, It basically is like a way of like your body getting scanned from head to toe. In general, we are able to see your insides properly. It's as if somebody chopped you with an axe, you know? Like it shows you it in an axial way. Yeah. Please beat my Wi-Fi up. Please, I need it. So the provisional diagnosis for this case is amoebic abscess. Because of the presentation, you know? Like the patient is already like, you know, traveled to a country which is a very risky place to get that. No offense to my Southeast Asian brothers, sisters, and non-binaries. But there are areas which are dangerous and you're more predisposed to getting that type of infection. So how do we confirm? How to confirm? So we have a thing called stool analysis. We have to do the first, like the initial thing we do is we test for like the stool and we check. So how do we confirm? Initial step, stool analysis. That's what we basically have to do. We can try to aspirate it. Then we aspirate it. What type of medications do we write? We write an antifungal. We write an antifungal called metronidazole. So basically it'll be metronidazole 3 times a day. Okay, so we basically just write it down 3 times a day. I would have restarted my PC, but I'm gonna be so honest, my PC has been really wonky. And this always happens when like my PC is just, you know, messy. I'm sorry guys, but like my PC is really bad and I need to send it to get fixed. It's really unfortunate that you guys have to deal with the delay. Like, I feel very guilty about it, but it's beyond what I can do. Like, it's really bad. I'm sorry. I don't know if it's because I have a lot of games on my PC, but it's just really hard. I'm sorry. I feel like guilty about this. Okay, so this is our first lesion. It's amoebic abscess. And this is how we manage it. So a summary basically is TLDR. Young age, right upper quadrant pain, dysentery, and abscess. This is how it's gonna come in my exams. Thank you for the head pats. But yeah, you guys are seeing me in my Angela Ziegler mood. I'm literally Angela Ziegler Overwatch. I hope you guys are enjoying like reading my notes. Hi Kronos, welcome to today's stream. How are you doing? Thank you so much for being here. Hi, I'm in my medical mood today, so you guys are just gonna be here while I study, okay? Okay, Pookie, so let's go to the other case. So we have 32-year-old male with dull pain, right hypochondriac region, with jaundice after 1 week. Hi, half of my heart. Hi, Orbion. Oh my god, I'm doing good. The Wi-Fi is just really bad and it's painful. I hope you enjoy your lurk, by the way, half of my heart. I'm doing a little bad because of the Wi-Fi, but I'm just happy that you guys are here. I'm just happy to get to, you know, have you guys here while I just study. You know? So basically, like I said, hypochondrial region. Basically, it's like your right, like I need to remember. I think it's like middle. Like it's not to the top and not to the bottom. Oh no, it's like the right upper quadrant. Okay. Okay, perfect. So it's like right upper quadrant. I would also suspect biliary stone. So if I were in this case, I would definitely suspect like biliary obstruction. We took proper history and we ended up doing an ultrasound and we got like a SpongeBob flower. Water lily sign. You just imagine one of these flowers you'd see like on SpongeBob, right? So this is basically the sign that it tells you that it's, you know, basically it just tells you that, you know, this is not normal, not a normal mass, not a biliary obstruction. So when we see the water lily sign, we basically end up confirming that it's a hiatal cyst. And when we do an ultrasound, you also see it in like a multi-daughter cyst. Wait, let me see the notes. Hold on. I think it's called multi-daughter cyst. Let me take a look at that. Oh, so it's like a cyst within a cyst. Okay, so it's a cyst within a cyst. Yes, it's a multi-daughter cyst. Interesting. I'm really sorry about the stream quality being on and off. But I hope you guys know I appreciate you all for being here. So how do we diagnose? We have to do a serology by something called ELISA. And we also can do imaging, like a CT scan. And biopsies are contraindicated because if you end up taking a biopsy from the mass, the cyst is just gonna explode and the patient is gonna get into an anaphylactic reaction, which will result in their possible death or deterioration of their condition. Biopsy is contraindicated. What is this? Oh, okay. That's actually so cool. Wait. Whoa, this is awesome. So let's just put this here. Make it a little section. No. Like this. This is good. I love being organized. But yes, you guys are just seeing the medical oomph in me. You know, I wanted to combine two things I love, streaming and medicine. I'm very far behind on my lectures, so I had to decide to lock in. I'm not too far behind, but I felt like I needed to study. So yes. Hold on, let me check my oomph. Oomph sent me something. Hold on. Oh my god, whoa, this is pretty. Hold on, y'all. I need to DM my own something. Give me a sec. Okay, sorry, I was DMing my artist too. Oh. Sorry, guys. Okay, back to the topic of study. So yeah, we want to not try to let the cyst explode. Like, a hiatus cyst, is very dangerous because once it explodes, it just results in an anaphylactic reaction. I wonder which microbe does cause a hiatus cyst. So a hiatus cyst is by Echinococcus tapeworms. Oh. Ew. Ew, they look disgusting. Oh my god, I would never be a general surgeon. I would die on the spot. They look nasty. They look horrifying. Do not look them up for your own good. Absolutely not. Never look them up. Okay, so there's that. It's a hiatus cyst. And how do you manage? So we have basically like two ways to handle. Like, you know, like there's like conservative treatment where we give the medications, and there's like a thing where we just do the surgery. So medications, antifungals, we use albendazole, so we can kill the organism. Albendazole or mebendazole. And then we do something called puncture, which is puncture, aspiration, installation, 20% hypertonic saline, and reaspiration. Like, it's basically we clean it up, we puncture it, we drain, we put more normal saline, which is hypertonic, and then we drain it again. Or we can just do surgery after, like we will do like the surgery after aspiration, but the main one is pair with albendazole. So either ways, We can also do an endoscopic clearance followed by a cyst removal from the liver. That's mainly to like resolve the jaundice. We want to resolve the jaundice. So like I said, what are the complications of like the surgery in general? Complications? So we have a laparot, like rupture with peritoneal seeding. So the peritoneum is part of the stomach, okay? Oh my god, I hit my dogs. Why are they barking? And there's also jaundice. And the worst part is anaphylactic shock, because if it ruptures inside of the patient will have an allergic reaction, okay? So that's why we have to put a stent before to prevent the seeding. We manage it by just putting a stent. So far we discussed amoebic abscesses, and we also discussed hiatal cyst. Alright guys, this is another reason why we're gonna like try to be more careful with having diabetes. So you guys, look at this 72-year-old male who's a known diabetic, complaints of anorexia, fever, malaise, and right quadrant discomfort. Okay, let's just make this bold so we can just separate them. And we gotta make it like a subheading or like a section. Eh? What the? After watching your streams a lot, I realized that 5 seconds is a really long time because it's the literal meaning behind creation disposable substances. Eh? Welcome, how are you doing? Thank you for being here. I don't know what that means. But I hope you're doing good. Thank you for the care package, Zephyr, and welcome. Anyways, let me hydrate. Anyways, we'll continue looking in for surgery stuff. How are you doing, by the way, Zephyr? Okay, so we basically, after like examining the patient, there was hepatomegaly. Like he was feeling pain, and there was visible liver enlargement. Oh my god, I hope work is treating you nice. Thank you for being here. Anyways, so after we did an ultrasound, like always guys, most of the times, like it's always history and then examination. But in these types of cases, we want to rule out malignancies and stuff. But this, especially because this patient is like 72 years old. 72 years old is really like old, and that's gonna be like a source and risk factor. But like usually like you'd see malignancies in this patient's age, especially because like, you know, anorexia, but at the same time you see like the fever and malaise. Like this sounds, yeah, I'm studying, Siege. I have to lock in. You know, I was feeling guilty that I couldn't really, you know, lock in. So I had to combine two things I love, studying and streaming. So you're watching me up about like benign liver masses. Okay, so once we did the ultrasound, because listen guys, when I tell you something, ultrasound is very affordable and it's everywhere. So the patient wouldn't really need to wait or in like lines and stuff. And like the only issue is that it's just controller dependent. Like You have to be the one that's holding the probe to handle everything. Hi, Mac. Welcome to today's stream. Thank you so much for being here. How are you doing? Today we are studying because, yes, I have to lock in. I have to lock in. Hold on, let's restart this. But like I said, so we are looking in with like the studying. So on ultrasound, we have multi-loculated cystic masses. And you also like the same thing is something that you notice. Oh, let me stretch too. The same thing is on the CT scan as well. Not bad, just stretch because my spine is fucked up. How are you? I'm doing amazing. I'm just happy that you're here. Let me just hydrate a little. Alright, Pookie, so CT scan says the same thing where we see a multinucleated cyst. No, we just see multiple cysts. Like, we just see multi-loculated, not nucleated. Okay. Oh, thank you, Mac. You're so sweet. Yeah, I'm just geeking out because I have to prepare for a quiz. So, what is our diagnosis? The diagnosis? Wait, let me just put a line here. Because if you put a line here, this will make things way easier. This one is an amoebic abscess. The diagnosis is something called pyogenic liver abscess. And usually these are in like people with weak immune systems. Or it can be like from a previous infection in another system. Like, there are people who have appendicitis, for example, right? And because of that, those people end up just having the infection spread to somewhere else. And the worst part is, after we have them be immunosuppressed. So the management is we have to aspirate it. No, wait, so we have to aspirate and then diagnose. Plus broad spectrum. Like, we just treat according to the, the cause. Because there's different types of bacteria and opportunistic pathogens. So we basically treat according to that. Oh my god, sorry guys for your ears. Yes. Okay, next thing. So broad spectrum is usually something called augmentin. Or it's basically amoxicillin clavulanic acid. Like, I just remember it as amoxiclav. That's like the commonest things. So we have something also called hepatic hemangioma. Hepatic hemangioma. It's the most common benign tumor. Like, literally, it's very common. Usually is an incidental finding. Guys, did you know that there's a tumor that's actually called incidentaloma? Like, you actually find it via coincidence. Like, you don't really have symptoms from it. It's just an incidental finding while you do images and stuff. Luckily, incidentaloma is not malignant, it's benign, so you do not need to worry about it much. Okay? Oh god, I just realized the coffee thing is just covering everything up. Okay, let me just take away that. Mokamin, what's the astronaut's favorite part of the computer? The space bar. Wow, you're so creative. I love dad jokes. Thank you, you're so amazing. This was amazing. Thank you, thank you. I love the dad jokes. You know what? Keep it a tradition. Keep bringing me dad jokes. I need to see the dad jokes myself from now on. Thank you. Sorry, I was hydrating. Okay. So right now we're talking about hepatic hemangioma. Let's make this bigger. Because, you know, the bigger the thing is, the better. Oh God! Oh no! What? I selected this, why did it make everything else bigger? What? This is crazy. Oh God, this is so disorganized, my OCD is gonna act up. Okay. Let's just organize it. So we want to like just keep doing it as like, you know, bulleted list. So yes. Alright, how about this one? Why do seagulls fly over the sea? Because if they flew over the bay... Wait. Why do seagulls fly over the sea? Because if they flew over the bay, they would be bagels. No. Dude, can I just say something? Like, I love the type of people who just come here and act wholesome. Like, I'm gonna be so honest. The fact that you just came and just started talking about dad jokes, that's like better than anything. That's just better than anything. Like, I've had people come here and just start up with the weirdest like topics ever. Like, you're just normal. You're actually amazing. Please, that's wholesome. Keep doing the dad jokes. I'm proud of you. But if you don't know, I am currently a 6-year medical school student, which means that I'm graduating soon. So I'm just trying to do better in my next quiz, so I can like hopefully get a B+ or an A+. I mean, A+ is impossible. We can try pushing for an A though. But if you have any medical questions, don't hesitate to always ask. So hepatic hemangioma, it's most common benign liver tumor. Liver tumor. Usually it's an incidental finding. Usually it's like it affects adults. Women more. No symptoms. Asymptomatic. Bivascular. Malformations. Why do rainbows go when they've been bad? To prism so they can have time to reflect on what they've done. No way. Oh my god. I mean, the prism is kind of cute though. I always love rainbows. It'll only be like symptomatic in general if it had like, if it was large enough. Like genuinely, if it's big enough, like it's just gonna compress on everything. So the person is gonna, like, who's affected by this is just gonna feel full. And like the rarest complications are like, it just, like, just imagine something big compressing you. Like, if the mass just ends up being very big, it's just gonna compress everything else. So let's talk about how to diagnose. Ultrasound is the initial imaging with hyperechoic lesion. Basically hyperechoic and hypoechoic. So hypoechoic, it's like a darker lesion, because ultrasounds are basically, we use like the sounds to formulate an image. So hypo means that there is no echo, which means that usually it's like a fluid-filled mass or like an air-filled mass. But with an hyperechoic lesion, usually you're gonna see basically like it being grayish. You're gonna see a visible mass. Like it's gonna be like more brighter. It's like dark versus light. Dark means that there's water there. Light means that there's like tissue, for example, like meat. You're just like, you know what I mean. After that, we continue with a CT scan. Enhanced in arterial phase, which shows peripheral nodular enlargement. Like you'll just notice a nodule in the CT scan. Okay? Like there's gonna be a visible mass. I wish I could show you guys the image. But you guys can look it up if you guys want. It's called hepatic hemangioma. And you can just look it up on the CT scan. Like this is something that you guys can like find, but it's not really like, something people would complain over. It's just an incidental finding. Alright? So what else? MRI usually is a gold standard though. So there's a sign called light bulb bright on the MRI. Let's see if I can get it for you guys. MRI hepatic hemangioma. I need to show you guys the sign. Oh my god, thank you, Daro. I need to show you guys the hepatic hemangioma. Oh, thank God for Radiopedia. Okay, so you guys, okay, let's go here. I'll show you guys just for visual demonstration. So you basically, do you see this? This is a right lobe. You can see the hyperdense. Do you see how bright it is? It's very bright. So yes, this is a hepatic hemangioma. Do you see how bright? Like, it's like a light bulb bright. It's very bright. Okay. So, as you guys can see, this is basically it. Alright, let's go back to talking about other normal things, including like, I don't know, other liver masses. But like I said, let's just remember that it's usually incidental finding, and you can just notice it on the MRI. You only do a follow-up if it's bigger than 5 centimeters. Only follow-up if it's bigger than 5 centimeters. If it's symptomatic, we basically intervene, especially if it's affecting a patient's daily life. Otherwise, we just put we just put them on, like, you know, just reassurement. Oh my god. Whoa, what is Kazan? What type of game is that? So like I said, no treatment is needed if it's, you know, no treatment is needed if it's asymptomatic. If it's bigger than 5 centimeters, we just follow up. If it is symptomatic, we basically intervene with surgery or embolization. We don't want to do a biopsy because biopsy causes bleeding. Because at the end of the day, this mass is made by abnormal vessels, okay? It's by vascular malformations. So the patient might be in an hemorrhage risk. Okay, so we have to avoid hepatic hemangiomas, but it's most commonly in like females. And we have, I think, 2 last topics to discuss before we're done with like the benign liver masses, and then we can go for the malignant ones. Okay, so let's talk about hepatic adenomas. Also, guys, this is a fun fact. If anyone tells you something about the hepatic system, that is basically them talking to you about your liver. Sorry guys, I was jamming my rooms anyways, because like artist stuff, you know, because I'm preparing more stuff for, I don't know. But yes, you guys are just listening to me geek out about medical stuff. To anyone who has any medical questions, do not hesitate to ask. Just know I'm a 6-year medical school student, so I might not know everything. Alright, so let's log in. Next topic, after hepatic adenomas. No, we're not done with hepatic adenomas. So, it's a benign liver tumor, usually linked to hormonal factors. OCPs, oral contraceptives, basically to any woman who's basically going through abnormal like a lot of hormonal changes. Usually young to middle-aged women. But it has a low chance of becoming malignant. Basically, it increases with size, with hormone use or pregnancy. Oh my god. Basically, the more you take oral contraceptives, it increases.
Hamter.
Oh my god, Hunter, hi Ray!
Hamter.
Oh my god, Ray, welcome to today's stream. How are you doing, Ray? Oh my god, Ray, you should have me as your background noise while I study. Wait, Ray, do you want to see like an MRI? Because you're gonna be a radiologist, right? Hold on. Okay, Ray, so tell me what is abnormal here, okay? Okay, Ray, so tell me what is abnormal here. What do you see here that is abnormal? Tell me. Good job, Ray! Good job. Yes, you're actually right. You're talking about this, right? Oh my god, Ray. So, this is something called hepatic hemangioma. It's the most benign liver tumor, and it's usually like more, like it just affects females mostly. It is caused by abnormal vascular malformation, like it's just by abnormal vessels. They just cause a mass. Like this is, I think it's quite a big mass, which is why they decided to do the MRI, which is why the patient had the symptoms. But normally it's asymptomatic, like it doesn't have symptoms at all. Okay? Oh my god. So do you get it right? Okay, we're basically talking about hepatic adenomas right now. And this is very good to be educated. Sorry. So we have a benign liver tumor called hepatic adenomas. Hepatic adenoma. It's actually mostly in females, mainly because, you know, it's related to hormonal factors. So if you're taking oral contraceptives, it may increase in size or it may be increased with pregnancy. Usually symptomatic or incidental finding. Same symptoms as hepatic hemangioma. The only risk is that it's at risk of having a rupture and hemorrhage if it's bigger than 5 centimeters. Yeah, if it ruptures, like for example, like just imagine like you have a water bubble, right? And suddenly part of it explodes, right? Everything just seeps out and like causes a huge amount of blood or like water out in general. So that like I'm just trying to use the analogy to help you imagine it, okay? So how do you confirm it? We basically do an ultrasound which shows hyperechoic or heterogeneous lesion. No, Ray, don't go. Ray, please stay with me. I want to talk to someone while I'm studying. Wait, oh my god, brains. No, please, don't go. Hold on. Okay, so let me show you like a picture of a hepatic adenoma, Ray. CT, let's see. Maybe Radiopedia is gonna have it. Radiopedia is my goat. Radiopedia is my goat. Alright. I'm trying to find a picture. Okay, so I think this is a CT. Okay, so Ray, do you see this? This is a CT. Oh god. Like, there's a white mass here. It's hyperechoic usually, right? And this is how you see it in ultrasound. This is what I meant by hyperechoic. You basically see like a bright mass. The brighter it is, that is a sign that it's hyperechoic. If it's not, then that's hypoechoic. Like it's opposite. Like you guys can figure it out. Inflammatory, you can see it over here. This is a liver, as you can see. Hold on, this is a liver. Oh my god, my mouse is very much dying sensitivity wise, but you know. It's because I don't really have much space here. Hold on. No, this is not the liver. No. This is front, okay? This is back. This is a liver. Yeah, this is, I think, maybe like the this is like the gallbladder, I think, or the bile duct. I'm not sure. I'm not really the expert here. I cannot interpret this, but you can just notice a mass here. I think this is an MRI. This should be an MRI. Yeah, it is an MRI. Oh, this is very multiple of them. Like you can notice from hepatic adenomatosis. Like you can see more than one. 1, 2, 3, 4. Ray, this is a good exercise for you because you want to be a radiologist, right? And this is another MRI. in T1 phase. You can see the mass here. I'm sorry if it's not too visible. Like, it just sucks that Radiopedia doesn't really show you much. Like, I wish it did show. Like, I wish it let me zoom in. Wait, I think it lets you. Wait. Wait, we can't see it here. Oh my god, Dre, are you gonna go to Pharma? Because Pharma is fine too. But you gotta be good at Biochem. Biochem is hard. Alright, let's go back here then. So, they both... Basically, hepatic adenoma is similar to hepatic hemangioma. But, basically, this one... Like, hepatic adenoma is related to hormone changes. So, CT shows rapid washout during arterial phase. I'm good at bio. I never took a chem class though. Ray, biochemistry is really annoying. If you're a masochist, then I would tell you to go there. Like, listen, Ray, I took biochemistry and I got a 60 out of it. I was gonna fail. It was very bad. Okay, so like the management for this is gonna be, for what is the management for hepatic adenomas? Treatment is to discontinue the hormonal therapy, surgical resection if bigger than 5 centimeters, regular follow-up imaging for smaller asymptomatic lesion. Hold on, smaller lesions without symptoms. Consider resections in males due to higher malignant potential. Wait, so it has a higher chance into like becoming cancer in men? I was doing in high school to do good in math, so my counselor sent me to physical science. It's okay, Ray. Some of us aren't born to be good at math. Me neither. I hope you know I was so bad at math. I will never forget the day my mom went to my teacher in like the parents teacher meeting. And like my teacher was like, she's doing her best. No, she's like, she could do better. I see so much potential in her. Brother, I was so bad at math. Math was not my forte. This is why I'm a doctor. Listen, I chose to be a doctor because I was mad at math. Oh, Ray. Ray, why are you living up to the stereotypes? I'm so disappointed in you. I'm so disappointed in you. Why are you living into the stereotypes? Oh my god, Ray. We can bond over our hatred for our high schools. Ray, I will never forget the nightmare experiences I've lived in mine. Mine were just dumb. Okay, last benign hepatic mass. Focal nodular hyperplasia. Benign? Second most common benign tumor. Bro, why are these tumors common in women? Why are they common in women? Dude, why did God have to do this to us women? Oh God, this is evil. This is evil. You know, Ray, I'm just glad you dodged the computer science part because unfortunately, AI is gonna take over that, and it's really stupid. I hate it. AI is gonna take over many things. I'm ready to die. Don't die, Ray. Wait, it's benign though. It's benign, so you don't need to worry. So it's most common in women that are 20 to 50 years old, asymptomatic, okay, this is good. It doesn't turn into cancer. It rarely turns to malignant. generally remains stable in size without risk to to rupture. 20 to 50, I'm so ready. Ray, this is something you don't know you're having. This is a benign mass. Like, it's something you won't know until, like, they do an MRI on you. Okay, Ray? Okay, so ultrasound. Hyperechoic or isoechoic with central scar. But let's take a look. It's called focal nodular hyperplasia. Radiopedia? Wait, let's see. Focal nodular hyperplasia. Should be there. Oh my god, they found it. Nice. Yeah, this is literally risky for females. Wait, why'd you skip it though? Why? Focal nodular hyperplasia. Guys, I didn't want to go back to the doctors and it wasn't anything serious. Wait, why did you have to do an ultrasound? Like, did you find a mass in your chest? But that was also post-period. Oh, okay. Can you tell me where you found it? Sorry if it's too much, like, information. Like, if you're not comfy talking about it, that's fine. But yeah. So, like, was it in, like, the upper part? Can you tell me, like, just imagine, hold on. I need to open MS Paint. Oh god, this is gonna be crazy. Okay, Ray. This is gonna be a visual demonstration. Wait, I'll just tell you. Okay, so, Ray? So this is the outer part, okay? This is the upper inner part. Wait, let's change colors. The red one is the inner part, okay? Because I need to tell you, I need to, like, make sure that you're okay. Sorry, which part is it? Like, is it like the right upper quadrant? Because if it is these parts, like, these parts are important. Near middle, like, is it closer to, wait, is it closer to, like, is it closer to, like, the right, or is it closer to the left? Because I'm gonna be so honest, I would recommend you do the ultrasound just in case. But knowing your age, my differential diagnosis would probably go into, like, fibroadenoma, or, like, maybe cystic changes, because that's normal for, like, you know, females to go through. And last year since it was like last year since I last did it. What did they tell you last year, Ray? But yeah, Ray, this is important. I would suggest you just, for the sake of it, just go do an ultrasound. Just go do an ultrasound. Try to like rebook your appointment. Ultrasounds are easy. They're accessible. I think you're too young for a mammogram, so you know. Okay. It's nothing threatening though, I remember that. Yeah, but still, it's good to monitor because there are cases where it happens to younger patients. And ultrasounds are easy, it won't take long. Welcome home, Samoy. I hope you shower and have fun with it, okay? I'm just gonna stay up and study. Okay, so Ray, always tell anyone you love about this. Chat, this is for every female in chat. You guys need to remember this. Oh, hi Green, finally I can tap on my phone. I'm not gonna talk too much because finals are evil. Yeah, Lucken, I believe in you. So if you guys see the red region, if anyone you know that's a woman has a mass here, like just imagine these are boobs and just imagine that, you know, this area is affected. Like it's usually middle-aged to like old females, and there is a risk factor that it is breast cancer, and there is higher predisposition if you are a person carrying the BRCA1 and BRCA2 genes. There's a gene that is called BRCA1. It's associated with breast cancer and other malignancies, but most commonly in females for breast cancer. So yes, BRCA1 and BRCA2, okay? And with these people who have the BRCA1 gene, we definitely recommend prophylactic mastectomies. We basically tell them, we're sorry, we have to cut off your breast because there's a chance it's gonna turn into malignancies. It's gonna turn to breast cancer. Okay? Ray, please don't die. Also, what is... Oh yeah, 120 stream streak. That's honestly amazing, Green. I'm so impressed. Alright, so we're gonna close this. I really should have done this for my midterm. I'm gonna probably do this for my finals. Okay, so... Oh yeah, we're supposed to look at the focal nodular hypoplasia. Oh yeah, this is another tumor. Like I said, it's the second most common benign tumor in the liver. It's usually in women. So, as you can see, wait, I think we can push this image out. So it looks like a spoke wheel pattern. If you see this sign, like it's, let me see if there's a spoke wheel sign. So basically, they end up looking like this, okay? This is a spoke wheel. The tumor is characteristically enough to look like this. Okay? Like you can see it here, but it's not that good of a quality. Like this imaging, the image quality is not the best. Thank God for Radiopedia though. Okay, we can see the kidneys here. I can't really see the mass here, but I think it's here. I really can see it. This is a vague image. It's not that good. Let's see. Okay, we can see some of it here. Wait, this is multiple. We can see one here. And there's two of them here. Interesting. Okay, this is a good image. This is very good for you guys to see. So you can see how this part here looks like a spoke wheel. There's like a black dot from far away. Wait. Whoa, wait, you can actually move it. Whoa, that's so cool. Wait. Alright, chat. So this is, do you see this? Spoke wheel pattern. You see this? This is a lever. And you can notice it here. Like, you see the circle? And the black dot. Okay? Ray, did you see it? This is what you have to get used to as a radiologist. But it's so cool. I can actually scroll it up and down. I love Radiopedia. Wait, I need to tell my oomph about this. I'm gonna tell Spectral about it. My medical oomph Spectral. Okay, let's tell Spectral. Where the fuck is Spectral? Spectral! I love Radiopedia! I love Radiopedia! It saved my life! I don't know what my oomph is doing right now, but I'm just yelling at them. Dude, they slapped him of the VTube studio on. No way. Picking up with medical topics is cute. Well, I have to study. It's a mandatory thing. Regardless, I'm locked in. Mocha, I have my patient in front of me. I will be following step by step. Okay, so I'm just explaining about some benign masses in the liver that are basically asymptomatic. Most of them, at least. But except these. We'll revisit them so we can help you later. Oh my god, did the music stop? Oh my god, we were studying so much the music actually stopped playing. I have to change the playlist. Do I have to cut them out or no? Well, I'll tell you when. Okay, so you have to cut out the masses if they are, you know, like an abscess, for example. Like, for example, in amoebic abscess, this one doesn't need surgery. You just cut. No, what I meant is like the other one, a hiatus. Hiatus and also pyogenic abscess. We need to like put we need to put a needle in and suck everything out, basically. The rest here is like only surgical if it's like severe with symptoms. Alright, so we're talking about focal nodular hyperplasia. And as we said, it looks like a wheel sign. So it starts as an ultrasound, and you can see like a spoke wheel on CT. MRI, there's a central scar. Oh! No treatment needed if asymptomatic. Okay, so basically no treatment needed if asymptomatic. We just keep it there. It's not something that's strong, you know? Going into surgery for something like that would actually be stupid. Okay. Another thing is, let's just see. We can just do imaging for follow-up. Like, it's not really necessary, but if the patient is like OCD-ish, you can just do it for them. But yes, surgical resection only if you doubt diagnosis or symptomatic. Alright, so we're gonna recap everything, okay, Fable? Since you weren't here from the beginning, I'll just give you a recap about everything. Alright, so let's start with this. So benign liver masses. This is not cancer. Okay, so basically young age comes with right upper quadrant pain. Like you know, like liver spot. Look up the hypochondriac. It's like right upper quadrant. Dysentery, bloody diarrhea. Basically, it's an abscess. So we do an ultrasound. We find cystic roundic lesion and double wall sign. This is a sign that it's, you know, yeah, how do I say this? It's basically an abscess, especially if he traveled to Southeast Asia. Most of the time they travel to, no offense, to like India or other areas that are developing. Okay, let's see. I need to change the music here. 6.4. Let's hope I can put this soundtrack. Hold on, I'm gonna put this soundtrack. I like this one. Alright. Hi, Castor. Thank you for the headpats. Okay, so basically, this is an abscess. It's by a fungal. It's by a fungi. So what we have to do is we write down the antifungal, which is metronidazole. But this is after we do a stool analysis. Then we aspirate from the abscess itself. Okay, we like sample it, and then we write antifungals after we confirm which culture it is. So the other case, basically, young male, same symptoms, but jaundice. If you guys don't know what jaundice is, it's the yellowing of like the eyes, the face, the lips, the nails. It's like visible color changes. It's a sign of like the liver being affected. So we do an ultrasound. It shows a water lily sign. Okay, let's see. I'll get a picture just to show it to you guys. What? We don't have hiatal cyst? Okay. Weird. I can't believe that they don't have the ultrasound for that. Okay, this is good. This is really good. You guys are gonna be able to distinguish it here. Okay, guys, so can you see this image? What do you think is abnormal here? It's very visible. Like, you guys like aren't even radiologists or medical students, and you guys can see it. Okay? So this is what you guys are going to be able to see. It's something called the water lily sign. Okay, so basically green. What is the abnormal thing here in the image? Okay, so which side is it? Tell me, Fable. Where is it? Where is the sign of the hiatal cyst? Of course, we'd order a lot of labs because there's a lot of diseases we have to rule out. But this is easy to like see in the exams because you are being handled with specific things. I'm gonna scare my friend with it. I need to send it to him in DMs. Yes. Yes. This is basically the liver, by the way, Green. This is an ultrasound. So if you guys want to see how it's an ultrasound. Do you see this? This is how an ultrasound moves. This is a liver. So see? This is a liver. Esophagus. Yes. So as you can see, these bumpy things that are called the water lily sign, this is basically a sign that you can notice, and it is very noticeable for like a hiatal cyst. Yes, it's okay. Do not worry about it. I'm gonna send it to my friend He's gonna be so scared. So yes, this is a hiatus cyst. Okay, like we it's notable by like the water lily sign. Okay, next symptom. Oh wait, we basically after we do like the CT scan on ultrasound, we basically just notice this thing. We end up sending it for serology via ELISA. Biopsy is contraindicated because if we like do a biopsy on it and one of them explodes, the patient is going to go into an anaphylactic reaction, okay? And basically we just give antifungals and aspirate it. We do puncture, aspiration, saline, aspiration. And this should basically eradicate it. Okay? Next disease is basically diabetes, anorexia, like anorexia, loss of appetite. No, I'm sorry, Feeble. Oh my god. Samoy, thank you for the gifted. Oh my god, you're so sweet for that. Thank you, Samoy. I hope you enjoy your ad-free experience now. Oh my god. That's really sweet. That's actually so sweet. Okay, so basically, let me give you a recap. Topic, like just a short summary. A person that's young, right upper quadrant, complaining of bloody diarrhea, and after going to a Southeast Asian country, you do an ultrasound and you find a visible double wall sign. This is basically by a microbe called Entamoeba histolica. Okay, so it's basically that. And it's basically an amoebic abscess. You treat it by antifungals for like 3 days before instead of taking the person to surgery. Wait, let's scare him. I need to scare my other friend. I'm gonna send him this random picture. Okay, back to the topic, sorry. Okay, so basically just antifungal for 3 times a day, metronidazole. Next case, same symptoms, but instead of dysentery, the person has jaundice, yellowing of the eyes and the other membranes. Basically, we do an ultrasound. It's the water lily sign. Oh my god, Fable, did you see the water lily sign? Or not yet? I think you saw it. You were typing. So we send it for a serology via ELISA. Biopsy is contraindicated. If you guys don't know what biopsy is, we take a sample of the tissue. But we can't do it in this case because if it explodes, the patient is going to go into an anaphylactic reaction, and we do not want that. So serology is always the best thing we can do. And we treat it by giving albendazole, and it's either albendazole or mebendazole, just antifungals. So we can just puncture it, aspirate, clean, puncture, aspirate, clean. And with this, we basically are done with it. What are the complications? Peritoneal seeding, basically more of like the microbe. It's like a tapeworm. It's just going to spread over the peritoneum, the abdomen in general. And, you know, we avoid it by putting a stent before we take the person to the surgery. Jaundice or anaphylactic shock. Anaphylactic shock being the worst. Okay. So, next topic. 72-year-old male who's a known diabetic with diabetes, like with anorexia. Anorexia is like not being able to eat, fever, and exhaustion, and right upper quadrant pain. The main part here is that he's basically diabetic. So guys, if you guys have anyone in your family who's diabetic, always know that they are like very much weak immune system. They have a weak immune system. Okay? Like their immune system is very weak, very bad. This is why you guys always have to be healthy, because diabetes is very dangerous. It affects your immune system very badly. Okay? What if they're diabetic and anxious? Well, no, this one like has fever and loss of appetite. They have to go. They have to get checked. It's important. It's important. It's very, very important. So, basically, we did an ultrasound and we found, like we examined, okay? The patient had a large liver, and he also feels pain. So we have to do an ultrasound to monitor. And we found that there is multiloculated cystic masses. Yeah, honestly, that's true. That is true, but it's mainly because of the diabetes. Yes, your anxiety and mental state does affect your immune system, but it's mainly the diabetes. It's the main elephant in the room. You know? I was just like, whoa. So, the diagnosis is pyogenic liver abscess. It usually targets old people because their immune system is weak, people who are diabetics, people who recently had a liver procedure. The treatment is we aspirate the cysts and we also give antibiotics. Like ideally broad spectrum antibiotics, which is amoxiclav. It's really common. Amoxiclav is really common. Everybody takes it. Like, there's high chances if you go to like a family medicine clinic practitioner and just ask a nurse there about amoxiclav, she's gonna be like, oh, I heard that. I heard that for sure. Okay. So let's continue. What else? Okay, next topic, hepatic hemangioma. So we have like basically many other benign liver masses, and unfortunately they're all affecting females. So we have hepatic hemangioma. It's the most common one out of all of them. It affects adult females more. Usually has no symptoms, but it's usually out of the it's because of issues with abnormal vascular malformations, like basically abnormal vessels. It's asymptomatic, only symptomatic if large enough. You can see hyperechoic lesions on ultrasound. We already saw it earlier, and we saw the light bulb sign. It is very bright, very bright. It's noticeable. We can't do biopsies because it causes bleeding. And we only do surgery if it's less than 5 centimeters, okay? Like, if it's above 5 centimeters and asymptomatic. Otherwise, you don't do much. Hepatic adenoma, like its treatment is nothing. It's just conservative and supportive. But if it's symptomatic, surgery. A hepatic adenoma is basically not as common, but it's only in females. Mostly in females. Mostly due to hormonal changes, okay? Okay, so like I said, it's usually in females. It worsens with the hormonal changes. Especially if like they're taking oral contraceptives or, you know, hormonal treatment and stuff. We stop the hormonal therapy if it's like that. Basically, that's the TLDR. Yep. Surgical resection if it's bigger than 5 centimeters. If it's in men, then we have to do surgery. Because cancer. Second most common mass is focal nodular hyperplasia. It's second commonest. Unfortunately, the girlies are affected more, you know. Never turns malignant. Management is surgical if it's if you doubt your diagnosis or is symptomatic. Okay, we're done with benign liver masses. Yay! First lecture done! Okay, so let's go through... Wait, guys. I need to do a poll and you guys are gonna decide, okay? I'm gonna do a poll so you guys can decide the next topic we can do. Because there's a lot of topics we can talk about. And they're all very educational, so... I'll start a poll right now. We're gonna make it 1 minute long, because why not? Bariatric surgery. GERD, because GERD is also common. Esophageal tumors. Gastric cancer. And mediastinal. Okay, guys, so you guys can pick whatever you want. Please vote in the poll and let me see what you guys want me to study on stream with you guys. I'm really scared. So, yes. What do you guys want to see? We'll just wait. Oh dear. Wait, I need to make this a little smaller. Give me a sec. I think I fixed it now. Oh no, it's so bad. So far we're at a tie. It's between GERD or esophageal tumors. You know, let's do GERD. GERD is easy, so we can finish it very fast. So we're gonna talk about GERD. Okay, we won't take much with it. Basically, gastroesophageal reflux is one of the most commonest things that anybody could be affected with. Oh my god. Sorry, I had to answer something IRL. Okay, so basically, GERD is one of the commonest things anybody could ever handle. And when it comes to GERD, it's basically like the reflux of gastric contents to the esophageal tract. Okay? Fun fact, I'm actually, like, my voice is deep right now because of GERD. I actually had a very severe case of GERD because I have something called a hiatal hernia. Okay? Basically, my stomach is turned inside. No, it's not vomiting. No. It's like vomiting is when it goes out of your system. It's basically internal vomiting. That's it. Like, just basically, you're like, it's like your stomach content going back. And you know how acidic the stomach is, right? Basically, it just affects and burns your esophageal lining, which is not prepared to deal with the acidity of the stomach. Yes, it is acid reflux. It's literally acid reflux. And that's why people go through heartburn. It's like a league lobby. Exactly. Reflux, basically TLDR, the summary of this disease is reflux of stomach acid more than normal amount. Symptoms plus esophageal injury. I'll tell you guys, we'll get to it. Let's handle it. Let's be patient, Green. Everyone has equal deposition, men and women, but usually it's in overweight people. Also depends on your diet. For example, if you eat spicy food, you're at deposition for GERD and gastritis because too much stress on the stomach. Usually it's an issue with the lower lower esophageal sphincter, okay? Sometimes it is due to the lower esophageal sphincter being incompetent. It's also because of like the diet. For example, if you drink tea, sometimes the tea lets the lower esophageal sphincter relax and be open. It's basically telling like a door that's closed, no, I'm just gonna leave it a little open and basically go back. Yeah, it is not good for your throat. And that's why my voice is deep right now. Like right now. Like, I don't know if you guys can notice the difference, but I can do it myself. Like, I can notice it. Like, the weird part at the end of my voice, it's because of this. Because of it's because people sometimes sleep after eating. And I do the same. It's really hard, you know? Because I get sleepy after eating. But yes, basically, could medication also influence the risk of it? Not sure, to be honest. It's mostly the diet. Usually it's... So let's talk about the causes of GERD, okay? Usually it's dietary, sleeping after eating, you know, sometimes like tea and other things that, yeah, that's dietary, like other things. I think achalasia, if I remember correctly. Hiatal hernia. So yes, hiatal hernia is the commonest cause. I actually have hiatal hernia, which is why my GERD is very severe. Not severe, but it's mediocre. I handle it with my own medications. I'll tell you guys it once we're done. So basically, GERD has a cycle, okay? The cycle is... So decrease lower esophageal sphincter, incompetent lower esophageal sphincter, reflux, that's the part when like the acid just goes back. And basically the esophageal mucosa isn't used for the stomach acidity, right? So esophageal mucosa contact with acid. Esophagitis. Then decrease peristalsis. It's like a vicious cycle. This is a vicious cycle. It just is a cycle. Like, it just affects it very badly. Okay? So, risk factors for GERD are impaired esophageal mucosal resistance, like the esophageal mucosa cannot resist the gastric acid. Poor esophageal motility. This is why I said achalasia. If you guys don't know, achalasia is a motility disorder in the esophagus. Yes, it's a disorder in the esophagus. And because of that, oh my god, I got like the biggest deja vu moment. I feel like I've lived through this before, which is weird. Okay, so let me just drink some water because my throat is dry. We hate esophagitis. Okay, so back to our topic. Poor esophageal motility. Lower esophageal sphincter dysfunction. Like, just imagine like the door to your house is open all the time. Of course the thieves are gonna go to your house. Of course the thieves are gonna go to your house. Literally. Okay, we continue. Oh my god. Ooh. Okay, let's continue. Sorry, I found a cute artist, so I might commission for stuff later. Anyways, so basically, let's talk about the symptoms. So what do you guys think are the symptoms for GERD, okay? Like, I already said some of them in chat. Like, acid is going through your esophageal lining. What do you think? Coughing? Yes, that's not typical, but it is gonna be in. That's gonna be in the last part. Come on, you guys. It's important. You guys need to start being engaged. This is a lecture with Dr. Mocha. But it is secondary to esophagitis. Swelling. Another one here. Come on, it's really obvious. Acid is going through your throat. What do you think you're gonna feel? What do you think you're gonna feel when the acid is going through your throat? It's really obvious. Acid burns. Yes. Burning pain. Heartburn. That's the most characteristic pain. Heartburn. And also acid regurgitation. Literally, acid burns, heartburn. Exactly. That's literally it. Like, literally. Okay. Basically, let me just continue this so we won't dwell on this lecture as much because this lecture is really easy. So acid burns. There's also going to be pain and difficulty on swallowing, okay? So basically, this is mainly the GERD symptoms. This is what you would feel. You guys dealt with heartburn before, right? You guys definitely felt like your chest was burning. I'm sure you guys also dealt with that. I'm dealing with it right now. Yep. Yes, that is true, Siege. There's something also called choking attacks. People sometimes wake up from their sleep because of the burning reaching their throat, and it's called a choking attack. Like, it's very painful. I actually had it happen to me once. But there are many diseases that have symptoms like that. So let's talk about differential diagnoses. Differential diagnoses are basically what we as doctors try to imagine. Okay, I don't really like this soundtrack. I really don't like this one. No, I like this one. Let's see this. Okay, so differential diagnoses are what are in like our minds as a doctor when we try to imagine. So when somebody comes to the ER due to severe pain, we imagine myocardial infarction because myocardial infarction and GERD have the same symptoms. And if you guys don't know, myocardial infarction is basically a stroke. Not literally, but like, you know, heart attack, my bad. I mistranslated. It's a heart attack. But the issue is, the difference is, it radiates to the arm, but GERD doesn't. GERD is literally there. There's a lot of differential diagnoses, for example, esophagitis, which is a side effect. We have esophageal stricture. People who drink bleach. Esophageal cancer. Foreign body ingestion. It depends. There's a lot of things. So what do we as doctors want to do? After we took history and examined the patient, we want to do a chest x-ray. Hold on. I need to see what the EGD. Oh! It's an endoscopy! Okay. Yeah, I was like, what is that? Okay, so we start with an x-ray, endoscopy, pH study, manometry. Listen, we just do the endoscopy and call it a day. We just ideally start with the endoscopy. Like, these are unrealistic. The manometry and the rest are like not really common. Like, we just mainly do the endoscopy and call it a day, okay guys? Basically, an endoscopy is when we put a tube down your throat with a camera and we try to see how things look from the inside. It's literally that. Okay? Okay, so what are the complications of GERD? So like I said, esophagitis, because your esophageal lining is being burnt, okay? Esophageal stricture, basically your esophagus becomes narrow. No, we don't. Oh my god. No, that's only when that happens when they're sleeping. No, it's not that bad, you know. Esophageal stricture, because you know, once you go through it, your esophagus is gonna narrow, and worst one is Barrett's esophagus. So guys, if you guys don't know, there's a thing. Wait, let's see. Radiopedia. Okay, could they aspirate? What do you mean? Hold on, let's see. Okay, Jared Radiopedia. Okay, this is a very good picture. Okay. Like, what do you mean aspirate? Like, what do you mean? Like, aspirate like the acid? Or does... I don't understand. Like, oh, are you talking about aspiration pneumonia? Oh my god, if they're sleeping and the gastric content gets to their lungs, yes, aspiration pneumonia can be possible, yes. Okay, so, Radiopedia. So, you can see the widening of the gastroesophageal junction with mild reflux of contrast at lower esophagus. Yes. They can actually breathe the acid, and it is something that causes aspiration pneumonia. Wait, let's see this. Ooh, wait. Whoa, this is so cool. Okay. So this is a hiatus hernia, okay? This is what I have. Oh god, I need to get a better angle for it. Okay. So you can see part of the stomach going through the esophagus. It's very small. Like, it's here. This is the esophageal tract. You can see part of the stomach going here. It's like strangulated. So you guys, basically this is hiatal hernia. Just imagine. Hold on, let's just take away my PNG for a little. Basically, it just like your stomach getting compressed. It is a risk factor. I actually have this, by the way. I have it. I have this, by the way. I'm being serious. I do have it. Okay, so let me show you guys one of the complications. Barrett's esophagus. This is a side effect from the constant burning. So look, this is a regular esophagus, right? Squamous lined esophagus. This is the tissue type that is in there. Ignore how many types I have open. I'm studying, I'm not playing games. So, you can see it. It's very normal for it to look like this. But then you can notice, hold on. You can notice how eroded it looks. Look at how eroded it looks in the Barrett's esophagus case. Okay? You can notice, look at the changes. Like, see? You can notice it here. No, this is a good picture. Like, look at how normal it looks here in the esophagus. Because the esophageal sphincter is closed. But here, you can see how eroded it looks. Everything is just gone down to hell. Okay? So this is Barrett's esophagus. This is a main complication. And if you had Barrett's esophagus, you're basically predisposed to cancer. Okay? You're predisposed to esophageal carcinoma. Oh my god, you guys are just listening to me change music. Alright, let's go back here. Yeah, no, no. Basically, the tissue in the esophagus changes. So, like I said, it changes from squamous, which is a normal biological tissue you have to have in that organ, to columnar. And abnormal changes in basically abnormal metaplasia. Metaplasia is the changes in the tissues. It predisposes you to cancer. Okay. So, guys, we have several treatments for GERD. Let's talk about the treatments. I think Green was here asking about the treatments. So we have conservative approach, which is what do we do in conservative? We tell the patient to adjust position before sleeping. Lying down on your right hip helps more than sleeping on your left. Or sleeping on your stomach does make it worse. Or you can sleep on your pillow. Make the pillow, like, elevate the pillow. Elevate the pillow. Stop smoking. Smoking does affect it. We also want to say that when it comes to counseling about GERD, weight loss is good. Avoid eating before sleep. This is basically the counseling we will do. Okay? This is how we handle GERD. Okay, Pookies? Keep notes of that. This is very common, so you guys might need this in your daily life. Okay. After that, we go for a more pharmacological treatment. We go with pharma treatment. We basically give PPI inhibitors. Just less spicy. You can avoid it before going to sleep. You can eat spicy food, but avoid it before going to sleep. Just avoid eating before going to bed. Fable is right. Fable is right. Do not go to sleep with a full stomach, okay? Okay, Pookies? Oh my god. Oh my god, wait, y'all. Oh. Y'all, I might try this out. Y'all, dude, some casting stuff literally just literally are opening stuff for POC stuff. Oh my god. Oh my god. Whoa. Loki might apply for the voice acting thing. Dude, yes, that's about the people of color. They gave a chance for us to be in in the voice acting thing. I really need to work on a demo reel, but the whole thing with the mic isn't even done yet. I look need to pray that we'll eventually get the mic done, and then I can work on a demo reel, and then it would be better. Sorry guys, imagine being a doctor and voice actor. That would be quite insane. Okay, never mind, ignore that. I was happy, so I'm just saving this for later. I need to save this for later. Oof, when would you stream? What do you... Yeah, honestly, it's gonna be easy. It's gonna be easy. I don't mind. I can balance my life. Honestly, I have a mic set up in mind, Green. Don't worry about it. Okay, back to the topic of Jared. Okay, let's finish Jared. Yeah, you showed it to me back then. Okay, so let's talk about Jared. Basically, we want to like reduce the acidity. We stop the acid by giving PPI inhibitors, which is stop the acid. Our goals is to basically reduce the gastroesophageal junction into the abdomen, which basically it just basically increases like an adequate length for the esophagus. Like it just gives it more length, so no more metaplasia. So we narrow like the hiatus to normal size because it's normally dilated, right? We want to make it normal. It has to be normal. Hold on. Give me a sec. I need to submit to this form. This is a good opportunity. Oh, hi, Echo Hops. Welcome to today's stream. How are you doing? Thank you so much for being here. We're talking about gastroesophageal reflux today. So if you're interested in hearing medical yapping, you're at the right place. Oh god, we need to save this for later. Yeah, and I enjoy the yapping. Yeah, you guys are forced to study with me for my exams. I have a quiz, so you guys are gonna deal with that. I like this OST, but it's not good for this type of mood. No. You know what? We need to change soundtracks. Okay. What else do I need to put? Okay, this is nice. Okay, guys, we are under the water. Yes. Anyways, back to the topic. So, junction into the abdomen and increase the length of the esophagus. Yes, Siege, you guys better. Listen, I'm so sad that I got like a 10 out of I got like a 10 out of 15 in my midterm, and I got a 10.5 out of 12 in my OSCE. So I was really sad. I was like, why? You know, I was an overachieving student. Now I'm going through like withdrawals. You know what I mean? So I'm very sad about it. So I need to lock in. Okay. So like we said, we basically can do surgeries, but surgery is always like last case scenario. So let's talk about the complications of the surgery. Complications. The esophagus might be perforated. There's going to be a hole in the esophagus. The spleen could be injured. So one of the surgeries is called Nissen funduplication. So it slips. Reflux recurrence. Difficulty swallowing. Belching or vomiting. Gas bloat syndrome. Wait, isn't gas bloat syndrome Borave? Let me see. I think it's supposed to be Borave. Ah. Basically, the stomach ends up being distended. Oh, it's okay, Echo Hops. I just appreciate that you dropped by, dear. Okay, so we got a lock in, y'all. Okay. Take care, Fable. Thank you for being here. So, basically, hiatal hernia. Like we said, we explained hiatal hernia. There's many types of it. And like I said, we can basically handle with the funduplication. Funduplication. So this is the type of the surgeries we do for the hiatal hernia. Most of the time we just do the Nissen one, but sometimes it slips. So it just makes the symptoms way worse as a complication. Like we always just do it. It's like not invasive. We don't cut through someone. We just do it laparoscopically. Okay, you guys? Okay, so this is the second lecture I have done. Yours is really easy. Yours is like one of the easiest lectures to do. So let's talk about malignant liver lesions. It's not going to be time consuming, fortunately. Malignant liver lesions. I really feel bad that you guys are like just sitting there watching me do this. Like I enjoy my medical yapping, but sometimes I'm scared. I feel like it's forced on you. Okay. Either ways. Lesion, basically it's like a mass. Okay, just imagine that there's a tumor. Okay. Okay, let's see. So, basically, it's like a malignant liver lesions are basically masses. They're cancers. So, in this case, an 87-year-old woman is referred to the surgical outpatient department. She has a 6-week history of constant right-sided abdominal pain, which radiates under the ribs and into her right shoulder. Okay, so she was referred to us by the outpatient department for surgery. She was fit well up until 4 years ago, when she had a right hemicolectomy. Basically, they removed the right side of like her colon for a Dukes B cecal adenocarcinoma. So she had a surgery before because of cancer in the colon. Oh, what is your specialty? I'm still an undergraduate. I'm a student. I am planning into getting into like internal medicine or something. But you specialize after 4 years after graduating from med school. And then you become a consultant in a certain topic or field. after doing a fellowship, ideally. Which I want to do. I want to do a fellowship. Okay? So like I said, when it comes to this, malignant liver lesions, about her case, she basically did a previous surgery, like 4 years ago, for a cancer that they found in her colon, okay? She did not want any post-operative, like she didn't take chemotherapy after the surgery. And there was no signs of metastasis after her surgery. But she realized that she lost weight, felt tired. She describes no changes in her bowel habits. So basically what I'm thinking from this case is it's metastasis. The cancer from previously didn't go like away because she didn't take chemo. Thank you, Mac. You're so kind, dear. So yes, on examination, there is no evidence of pallor, jaundice, clubbing, or lymphadenopathy, no visible lymph node enlargement. The nails are not abnormal. Anterior pelvic tilt? I think that's orthopedics, no? Oh, yes. Oh, yeah, it's lordosis. Yeah, it causes lordosis. Yes, yes. I know a little about it. Usually, you know, you can like go for orthopedics if you can, unless it's expensive. You can just handle it by exercising. Avoid setting posture checks and ensure the proper desk setup. Because basically, there's something that's called clubbing, okay? The nails end up being very big. Like, it's usually an underlying symptom that shows cancer, heart disease. Like, for example, it just shows a lot of things. I'll have to show you. You can look it up. There's a lot of exercises on YouTube. I think it'll show you. Like, I don't really have the exercises in mind, to be honest, but yes. So let me show you what nail clubbing is, okay? So guys, this is, look at this guy's nails, okay? We basically tell the patient to do this, and the size here is not normal. Like, you can see they're touching each other. No, don't apologize. It's okay. My job as a doctor is to help. So this is nail clubbing, see? Oh god, the picture is not that big. Okay, so you can see clubbed fingers, normal angle of nail bed, distorted angle of nail bed. Okay? So she didn't have that basically for our little patient. The chest was clear, heart sounds are normal. Palpable, though when we examined the liver, she had palpable irregular liver border about 3 centimeters below the costal margin. It's basically big. Yeah, they're not supposed to be like that. Unless it's familial, then it's just like that. That's sometimes a person's family, okay? Like, you gotta think, that thing could be because of a person's family, okay? Like, you know, oh, my brother is like that. Yeah, he's normal. Yeah, you know, I was born with this. Okay. Like, many things could be, like, abnormal. For example, somebody being underweight, but it's like, his BMI is normal, but it's just his family being like that. You know, a lot of things run in, like, the family blood in general, okay? So, what they found in her CT was very big amount of masses. So what does she have? Our patient had metastatic liver disease. Because, you know, so she didn't want to take chemo after her surgery, right? Which is something that you always have to do. Please take care. Thank you for being here, Mac. So yes, if you know anyone who's taking surgery, surgery itself can be curative, not curative. Like it's a good treatment, but it depends on the tumor itself. Like sometimes you gotta do surgery and then chemo. Sometimes it's chemo, then surgery, then chemo, just to guarantee that the mass and tumor is gone. It depends on the cancer staging. So our patient had metastatic liver disease. How do we confirm it? We saw the multiple masses in her CT scan, so we can take a CT guided biopsy. Okay, you guys, CT guided biopsy is very good for anterior masses and the masses on the posterior side. It's good for the front and the back. The middle one is endoscopic guided biopsy. We put a tube down and then we took the biopsy. Oh my god. I feel so bad. You guys have to hear me. So let's continue. These are like x-rays for soft tissue, right? But it's more of axial. Like there are many ways you can take the CT scan, but like I said, literally, basically, it's like you can just look up a CT scan, CT. It's really good, but MRI is better for soft tissue. MRI is way better. CT just shows stuff in more detail. Like X-ray doesn't show you like a person being chopped up from the inside while being alive at the same. You know what I mean? So CT guided biopsy, we have to do it under the CT guide. So what do? We do a triple phase CT chest, abdomen, pelvis. Ultrasound. Welcome to the stream, Happy York. How are you doing? Ultrasounds are usually the initial step. Like there are not, like sometimes you're gonna see stuff visible on them, but CT is more specific. Ultrasound is an initial thing because ultrasounds are affordable. They're everywhere. The only disadvantage is that they are controller dependent. Okay? But if you want to assess for like cancer, we ideally want to do a CT scan or an we have several scans you can do. We start with a CT. We can continue to MRI, and then worst case scenario is a PET scan if we want to check for possible metastasis. Metastasis as in like that tumor spreading. So basically we start with a CT, like we said, triple phase CT with chest, abdomen, pelvis. Contrast MRI for the liver because, you know, we're talking about liver malignant lesions. And whole body PET scan, like I said. So there's this thing called Child-Turcotte-Pur classification because it helps us classify the level of like hepatocellular function in liver cirrhosis. And when it comes to liver cirrhosis, that is honestly one of the main risk factors for hepatocellular carcinoma. Yes. So let's take a look at Child-Turcotte-Pur criteria. Okay guys, so we're gonna open this picture. Hold on. Okay, so we have something called Child-Turcotte-Pur criteria. Let's zoom in so you guys can see better. Okay, so we have to calculate it. It's A, B, C, okay? Because the stagement A? Oh my god! Wow! Thank you so much for the raid and welcome to the stream, Akazuiko. Hi everyone! Thank you so much for your, like, lovely blessing. I'm so grateful. Oh my god, Sish, can you give Akazuiko a shout out? Hello again, studies going well? Yes, we're talking about liver cancer. Oh my god, how is the music? Did you have fun? Hello raiders, if you guys don't know, I'm Mokamine. I'm your one and only angelic VTuber. Who's actually a sad med school student doing her best to survive med school. I'm 6 years, so I graduate soon, so I'm gonna be an intern doctor soon. But either ways, welcome! Thank you so much. If you're tired after your stream, do not hesitate to go get some rest. Currently, we discussed gastroesophageal reflux disease. We talked about benign liver lesions, and now we're talking about the metastatic liver diseases that are tasked by my college for my exams. All right, get some water. Feel free to come back if you want to. Don't hesitate to get some rest, and your after stream care, darling. I need to get some water. My throat is dry. Hold on. Okay. So, we have to calculate the serum bilirubin. We usually try to check if it's 34 to 50. In my lecture, it says 34 to 50. Let me stretch. Okay, nice. Hold on, let me adjust my sitting position. Oh my god. Yes, good. Let's study together. Okay, so, like I said, we have to check multiple parameters. So bilirubin and albumin are very good for the liver. You can just they tell us a lot about the liver's condition. So, if it's less than 34, then it's 1, 34 to 50, it's 2, 50 plus, it's basically 3. 30 to wait, this is weird. The one in my lecture says 2025. 35 to 25. I'm gonna ignore this. I'm gonna study the one in my lecture. Maybe this one's outdated. So, and the last one is less than 25. Less than 25 albumin means that it's stage 3, which is bad. Okay? So we have to check ascites. Ascites, if you guys don't know. No. Well, it depends. The lower the albumin is, the better the liver is. The more the bilirubin is, the bad it is. Okay? So, ascites. Ascites, if you guys don't know, I need to find it. Oh my god. Okay. So, ascites basically is abnormal fluid accumulation in the stomach, okay? Look at how big this guy's belly is. Like, this is a good example. Like, you see, this is a skinny patient, right? Skinny patient, but his abdomen is distended and full of fluid. There are multiple examinations we do, which is shifting dullness, fluid thrill. They're very telling of like the severity of this patient's ascites. Sometimes it's mild, sometimes it's severe. Okay? Like you can see, the peritoneum is just the under the peritoneum is full of fluids. Okay. Okay, no, I don't not want to get my stream copyrighted or punished for stuff. Okay, so you guys got it. Okay, you guys get the idea. Back to here. Prothrombin time is basically like we check how fast your blood coagulates. Okay? Because it's a sign that your body is unable, like if your body doesn't coagulate properly or coagulates too much, it is an issue with the prothrombin time. This is a topic, by the way. So Siege, you know Frost, right? Frost always has to get his prothrombin time checked sometimes because he has a condition called hemophilia A, which affects males and causes prolonged bleeding because of a factor deficiency. So yeah, so for example, if you were to meet Frost in real life and you guys, God forbid, get into a car accident, you have to take him to the ER as soon as possible. Instant blood transfusion because the bleeding is gonna be very bad, very horrible. Okay. So why do we have to know the Child-Pugh classification of cirrhosis? Because we want to see the liver survivability. This is very important, especially if you want to do liver transplant. Okay? So, for example, God forbid our patient had all of the criteria for CTPC. So this is either we transplant a liver or we send them into palliative care. Palliative means, yeah, sorry, you're gonna die. We have to take care and relieve your symptoms before you die. It's either or. It's either or. Like if we don't get a liver in time. In my case, I'm just gonna be like a normal doctor, so refer to like liver transplant center. I don't know much. I'm not a surgeon, but yeah, you have to refer to that. And I hope you guys know, transplanting organs in general is a very hard thing, especially even for like the person who's gotten like the organs transplanted to them, because they have to take immunosuppressants to suppress the immune system, because you're introducing a foreign body to like the body. So they're gonna have to be like basically immunodeficient for the rest of their life, because we do not want them to attack their own like the new organ. Okay? So let's go back to our little note thing. Okay, Pookies, let's go back here. So, for example, there's multiple options. Resection, it depends if it's like early staging. For example, CTPA, we can do it. We can resect the part where the liver is affected by the cancer. CTPC, we cannot do that because surgery is not good for that. It's either we go for the palliative route or we do surgery. Or we can also do chemotherapy too. Chemotherapy. Okay? So when we are going to treat a person with metastatic cancer, that's good, Siege. Excellent. So when we're dealing with cancer, we have to have a holistic approach, a multidisciplinary team. We do not need one doctor to handle. We have a whole board to handle the patient. We have an oncologist. We have a social worker. We have the surgeons. We have many things. There's a whole board to see how we're going to handle the patient. All right. If you guys have any questions, I'll do my best to answer. I'm still a student, so I hope that this is educational. Okay. So in our case, the person is CTPC. So we might have to basically just put her on chemo and just take the whole liver out and wait for a liver transplant. How far in do they need to experience hepatic encephalopathy with cirrhosis? I would say it wouldn't be early. It's one of these things that gradually worsen. The more it goes, the more it worsens. All right. Because, yes. Oh my god, I'm so embarrassed. It's mainly due to that, hold on, let me breathe. Let me just prepare myself. Because the ammonia just accumulates in the blood and reaches the brain. Yes? So the more the ammonia is accumulated, the worse it will be. Because, I think there is something called uremic encephalopathy with people who are dealing with dialysis, I think. Okay. So the good question is, can liver metastasis be resected? Yes. And it is the best option if the liver resection can be possible. No contraindication. Though we must remember, any liver metastasis can be resected if the function of the liver is 25% or more after resection. Okay. Okay, then we basically handled the first case, which is metastatic liver disease. Oh, I can breathe. Oh my god, sorry, I need to take my breath. Talking too much can be so exhausting. Okay, so let's continue. The liver is still looking do Wolverine? That's crazy. Okay, so let's talk more, okay? We have the next topic, which is going to be hepatocellular carcinoma, basically liver cancer. So listen carefully because we're going to read the case together. 54-year-old patient on follow-up ultrasound for chronic liver disease. There was a suspicious mass in the left lobe of the liver. What should be the provisional diagnosis? So we have to examine. Oh, fine. I find it very funny that I'm gonna look like a bunny while I explain this. You know what? Sure, fine. Hello? Hello? I'm Bunny Moga. Hi. So you guys are gonna watch a bunny talk to you about medicine? Professor Bunny Mocha? No way. You guys are wild. But yes, so we're gonna talk about hepatocellular carcinoma after. So we had the 54-year-old patient come to us. Okay. HCC, hold on. Because I'm too lazy to type it out. So, the provisional diagnosis is cancer to proven or otherwise. Because history of chronic liver disease. So chronic liver disease must have cirrhosis. And the most strong risk factor for it is, like, there are two factors, okay? There are many factors, but the strongest ones are hepatitis B, those are like the strong ones, or other liver diseases, diabetes, non-alcoholic fatty liver disease, aflatoxins, which is basically fungi, and worst case scenario, excessive alcohol usage. Oh my god, I feel like you guys are not able to see this. How to make this bigger? Wait, this is really good. This is really good. I just realized. I'm sorry, guys. Now you guys should be able to read. Wait, I actually have some glasses on me. Hold on. Hold on, I'm using the Persona PNG one. This looks so goofy. Hi guys. You got Professor Bunny Mocha. And we're talking about liver cancers. Are you guys proud? Are you guys gonna listen to me? Are you guys gonna be educated about the cancers? Thank you for that. Okay, so at the start, the cancer is gonna be asymptomatic, okay? Then you're gonna have loss of weight, loss of appetite, upper abdominal pain, nausea and vomiting. Like, just imagine like a person deteriorating in front of you, okay? But generally, most of the time it's just loss of appetite, weight loss. Sometimes it's pain, sometimes it's not. And then it's like the more it gets worse, the more the jaundice, the hepatic encephalopathy. Hold on, oh my god. Typing with a pen is a nightmare. Oh Oh my god. Oh my god. I'm crying. I'm sending this to my friend. I'm a bunny talking about cancers. Alright, back to our topic. Mocha is a cat. I'm a bunny, for God's sake! You need to get it right! I'm a bunny! 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 Chat, kill this man! Okay. Anyways, Doug, what is my doctor doing? Dude, if I was your doctor, like, listen, if I was my doctor, I would be filing for a medical malpractice lawsuit. I am too French to be killed. Bonsoir. Hello, Benny Sadana. Welcome to today's stream. How are you doing? Thank you so much for being part of the YouTube stream. We're talking about liver cancers while I'm studying for my exam, so I hope you enjoy your time here. I'm just studying right now, so yes. So we started by talking about metastatic liver diseases, and now we're talking about hepatocellular carcinoma, which is liver cancer. And we're talking about the symptoms in general. So how do we know the prognosis? So we have something called the TNM factor. TNM, always a TNM, it is very good. We also have, performance status test, PST, and we have the Child-Turcotte classification that we mentioned earlier. We have to do that because, yes, we have to see how things are in the liver because liver transplant. So TNM, basically it's tumor, lymph node, metastasis, like classification. Like sometimes when you do the imaging versus surgery, it's way different. That is why surgery is very good to see how the tumor is. You know what I mean? Okay? Okay. So let's talk about the performance status test. PST. So PST 0. Hold on. 0 is fully active. 1 can't do heavy work but can work. 2 is can't take care of themselves. 3 is basically, hold on. 3 is basically by like they're on their bed or share for half of the day. Okay, so basically it just gradually worsens. 0 is you can do very much. Activities, you're normal. 1 is that you can do a lot of things but not heavy work. 2 is that you basically can take care of yourself but you can't do work in general. And then there's basically the amount of time you sit. Okay, any questions for now? No questions. Alright, so what type of imaging we're gonna do here? We're gonna do the same thing. Literally, we're just gonna do the same thing here. We're just gonna copy paste this. But the PET scan is not the thing we want to do. Hi Vaya, welcome to today's stream. How are you doing? Thank you for being here. Thank you for your daily offerings to the Tree of Life. As you can see, I'm Bunny Mocha. I'm Doctor. I need to ask my friend this question. I need to ask them. Hi Shoto. Yes, we're talking about liver cancers right now. We talked about metastatic liver diseases, and we also talked about the hepatocellular carcinoma. So imaging is the same. We just copy the imaging here because it's the same. So what are the contraindications for surgical surgery in hepatocellular carcinoma? So basically metastasis everywhere. More like it's not localized, it's multiple and in both lobes of the liver. Done. So what is CBD? Common bile duct. Okay, so it affects the common bile duct. Okay. Okay. Common bile duct or tumor thrombus in portal vein or inferior vena cava. Yeah, no, it's basically CBT. So yes, if the CBT is in like CBT, common bile duct, CBD. Oh my god. My accent, curse my accent. Curse my accent, man. Thank you, Happy. You're so good at. Okay, let me charge my phone because like my iPad is already full now and I'm studying on my iPad. Okay, so what are the treatment options for this patient for the hepatocellular carcinoma? Resection, especially like surgery is always a mainstay. Like we start with surgery unless contraindicated. We can try something called transcatheter. Wait, it's called TACE, okay? TACE. Transcatheter arterial hemoembolization. I need to look it up. Yes. Yes. Oh my god. Hold on, let's take a look. I'm grabbing a picture right now. Let's see. How does the procedure look? Okay, guys. I got a picture so we can see it together. So let's just zoom into the picture. So as you can see, this is a liver, this is a tumor, yes? There is a catheter for injecting the chemotherapy into the embolic material. Basically. Catheter for injecting the chemotherapy drug mixture and embolic material. We'll just put it here. So we supply to the blood vessels, so it reaches there. Yes. Well, it's not really direct. We just give it to the liver. And like the blood supply also supplies to the tumor. So we're basically hitting it. But it's really rough if it's metastasis. I mean, surgical resection would be good, but at the same time. Okay, so like I said, they're gonna do this to me when I'm older. Cue the stinky sound effect. No, wait, do you have any cancer in your family, Shoto? Any cancers? Okay, back to the topic. So we can do radiofrequency ablation. Chemo, last case is liver transplant. So what do we do to screen liver cancer? So what do we do to screen liver cancer? So chat, you guys have to answer. What do we do? No cheating. The bunny is asking. Any ideas? I'll just type one of them out, but we did talk about the imaging earlier. Alpha fetoprotein is one of the things we use to monitor. So tell me, what do we do? Good job, Javi. Good job. Yes, we do ultrasounds. Ultrasound. Excellent. I passed through one with the tumor on my kidney. Oh. You should stop drinking then. Drink less. We don't want you to get cirrhosis. Okay, drinking is one of the causes. But what cancer in the kidney did you have? Is it Wilms tumor? I think it's Wilms, if I remember. Forgot, to be honest. Oh my god, we did 3 lectures. I'm impressed. Good job to us, to be honest. Alright, do you guys want to like do a poll on like the topic we study next on stream? I'll make a poll. I'll make a poll for you guys. You guys are gonna decide. So we're gonna talk about esophageal motility disorders. Well, we actually did the majority of the lectures. Excellent! I'm so happy. Like, this is like a week's worth of lectures, by the way. I need to make sure that all of them are over there. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 lectures. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, 9 lectures in a week. Okay. Excellent. No missing files. I just need to check like my study table for a sec. Just give me a sec, you guys. That's a study guide. Okay, so we did this. Hold on. Let me just write it down. Checklist. Checklist. Okay, so we did Geroid and hiatal hernia. Yes. Esophageal cancer. Not yet. Peptic ulcer disease. I have to read later. Okay. Okay, let's type it down. It's pretty standard procedure. Recovery just blows. Yeah, recovery is always tough post-op. If we're lecturing it, let's see if I can open my big book that I got as a flight mat could help. Okay, so I'm still working the poll. Okay, so let's see. Okay, so we have esophageal motility disorder, mediastinal diseases. What else? What else? Curses. I'm so clumsy. I'm so clumsy. Okay. Esophageal cancer. Okay, esophageal tumors. We did 3, so we have like 6 left. Bariatric surgery. Did I put gastric cancer? Oh yeah, let's put it in. Alright guys, the poll is here. You guys can decide on which topic we can talk about next. Oh my god, thank you so much for becoming a Divine Seraphim. I'm so grateful and I hope you enjoy your stay here. This is really sweet. I'm so grateful. Today was supposed to be my last stream before I send my PC for repairs, but I am gonna be in a collab on Saturday. I might stream tomorrow for studying if you guys are up for it. So you guys can vote. It's gonna end in like a minute. Okay, once the poll is done, I don't mind taking a look at the results. Oh, it's a tie between esophageal motility disorders, esophageal tumors, bariatric surgery. So I might have to do a spin wheel thing. Okay. So spin wheel. Okay, let's do it. I'm making a wheel right now. Give me a sec. Okay, what else do we have? Esophageal motility disorders, esophageal tumors, and bariatric surgery. Okay, we're gonna make a wheel right now. Alright, so who are we going to win? Esophageal tumors, okay. So it is esophageal tumors time then. Okay guys, be prepared, it's gonna be a long one. It's gonna be a long one. As if the others weren't long already. Bro, I sound like a sad mom. Ooh, that's funky, Shoto. Alright. Esophageal tumors. Oh dear. Okay, so this is a title. Esophageal tumors. I don't know why I just started meowing. I just started standing. Bro, just imagine I'm talking to my patient and I just start freaking meowing. Oh, I would die. You guys would never be hearing of me ever again. Absolutely not. You guys would never. Never. Okay? Okay. Exactly, how? You're not supposed to do much. You're a medic, for God's sake. We're doctors. We're capable. You're not. No offense. Okay, so let's start by talking about benign esophageal tumors. The benign ones. So let's start with the benign ones, okay? So what masses do we have? We have, wait, let's make a list. Leiomyoma, intraluminal polyp, hemangioma. Dude, we already got the liver hemangioma. We got the hepatic one earlier. Okay? They're not tumors because an esophageal cyst is basically a sac full of fluids. So we're just imagining like actual masses made out of tissues. So because like a cyst is way different than a mass. Like they're both masses, like basically, you know, they're made out of tissues. Okay. Oh my god, my brain's fried. Okay, hemangioma. Granular cell myoblastoma. Okay. So we're gonna start by talking about leiomyoma. Most commonly benign, but there's lesser than 1% chance, very rare, of it to turn into like esophageal malignancy. Because listen guys, there is nothing known as impossibility in medicine. Everything is possible. I sound so nerdy. Oh god. Dog, what is my streamer doing? Who is the streamer? Why are we letting her on? So, leiomyomas affect the males more than females. It's like a 2-to-1 ratio. Usually in the ages of 20 to 50 years old. Like we said in the liver lectures, asymptomatic unless bigger than 5 centimeters. So how do we investigate it? Endoscopy, barium swallow, plus CT. What the hell is a VAT? Let's see. Oh, video assisted thoracoscopy surgery. Okay guys, if you guys want to see what I'm saying, this is what I'm saying. So this is basically video assisted thoracic surgery. Okay? Yes. Perfect. Deliberate. And we can also do a thoracotomy. Enucleation. Oh. Interesting. Yeah, thoracotomy, I think, is... Oh. Interesting. Ooh, I don't want to put Goro on stream! We're looking at the medical procedures for leiomyoma. Okay? So what is the treatment for it? Thoracotomy or VATS? Do you see what I have to remember? Luckily our tests are MCQ, so we don't need to suffer. Yes. Meatballs, huh? So, for some reason my lecture didn't delve deep to the other stuff, so we're gonna start with like the lesions that are soon to be changed. So we're gonna skip Barrett's esophagus because we already talked about it. It is the main risk factor that causes adenocarcinoma, more common in males, especially Caucasians. GERD, obesity, alcohol, and smoking. Yep. We already talked about it. Wait, there are things we didn't talk about. Let's just skip till we get to the important things that we never spoke about on stream. Oh my god, no! No! What is this? What is this? Oh. Doc, what is my doctor on? What is my doctor on? Guys, you guys need to get a new doctor. I'm not a good doctor. Change. We need a refund. We need a switch. Okay, I'm joking. So, let's talk about Barrett's esophagus. So, we already saw like the different types of changes in the Barrett's esophagus, by which the squamous tissues change into columnar. So let's go with the results. Okay, so what do we do after we get the results of the endoscopy? So there's 3 ways. No dysplasia, repeat endoscopy with 1 year to confirm, then endoscopy every 3 years. We have to monitor low-grade dysplasia, repeat in 6 months to rule out. What the hell is an HGD? What? Let's see. HGD. High-grade dysplasia. Okay, so we want to rule out high-grade dysplasia. Okay. Plus expert pathologist consultation. We have to see if the pathologist can confirm it. If not, then with the low grade dysplasia, we basically do it yearly. Yearly endoscopy until no dysplasia for 2 years. High grade dysplasia, we repeat it. Repeat in 3 months to rule out cancer, plus expert pathologist. So we have 2 types of things we can do, right? We have one which is flat mucosa, like the tissues inside are flat. We can continue 3 months of surveillance and intervention based on the result. Mucosal irregularity, endoscopic surgery. Basically, let's give you a recap. So no dysphagia every 3 years, and if we repeat it in a year and there's still no dysplasia, okay. Low grade dysplasia, which is the second stage. Basically, if we have low grade, we repeat in 6 months to rule out, and then we check with a pathologist, and then we just continue doing endoscopy every year until no dysplasia for 2 years. Okay. The last part is we repeat in 3 months, and then we just do it every year until wait, let's see. No, it just depends on the result here. Okay, from Barrett's to esophageal, yes. We already spoke about it. So how do we treat it? Dude, pathology is actually sick. I think it takes you 4 years, PPI. Well, PPI is to manage, it's to manage GERD before it becomes Barrett's esophagus. Yes. We actually spoke about it earlier. But yes, PPI is ideally the mainstay treatment but if it's Barrett's esophagus, it's a little too late. Hi Solani, we're studying medicine today. You missed out. We studied liver tumors, benign and malignant, and we studied about GERD, gastroesophageal reflux disease, and now we're studying about esophageal cancers. Hi Lonnie, how are you doing, darling? Let me give you a shout out in a sec. Hold on, I dropped something, but yes. Can't you see I'm a bunny doctor telling you stuff? You have to listen to me, Lonnie. Instead of playing IDV or streaming IDV, I'm very productive. I actually have till July left. July 1 is my internship, so I'm gonna be an intern doctor by then. Good, listen to the bunny. Okay, so wait, let me give you a shout out. Good. Yes, I graduate this year. I'm so excited, man. No problem. So let's talk about the management. Management of Barrett's esophagus. So Barrett's esophagus is a complication after constant neglected GERD, if you don't know what GERD is. I'm too lazy to re-explain what GERD is, but it's basically heartburn, okay? Oh dear God. Anyways, so back to the topic we're talking about. We're talking about the management of basically esophageal cancers. So Barrett's esophagus is basically changes that will happen before cancer. There's a chance it won't turn to cancer, but it is most likely to turn into cancer, okay? So what are the management? We already said radiofrequency ablation, endoscopic mucosal resection. basically we do it in the middle of an endoscopy. Like in the middle of the endoscopy, we just cut it off. And we have knife resection. This one is more invasive. And we can also like continue like the hiatal hernia treatments. If the person has high-grade dysplasia, we can just do esophagectomy. We just remove the esophagus in its entirety. Okay, so now we're gonna go to malignant esophagus lesions. So we're gonna go with like the malignant esophagus lesions. Eh? If you guys have any questions for now, you can stop me, but I can't guarantee that I can answer all of them. I'm not an expert. I'm a student, you know? But yes, I'm graduating this year, Lani. I do not know why I suddenly got an accent, but yes. This is so stupid. But yes, hi, I love yapping about medicine. Alright, cuties, so let's continue about malignant tumors. We're talking about malignant lesions. So what are we going to talk about today? We're going to talk about squamous cell carcinoma, adenocarcinoma, leiomyosarcoma. Those are the ones that we're going to be covering. So in general, yes, basically, Shota, my dear. So gastroesophageal reflux disease turns into Barrett's esophagus, which is the thing we spoke about. It's a side effect, a complication of GERD. Yes. I hope this is visible. Okay, so you see this, right? Uh-huh. You see this? Mm-hmm. Mm-hmm. Good. Excellent. Now we can go back to our topics. I'm really happy you guys are actually enjoying this. Because if you guys enjoy it, I can actually do it tomorrow. And we can just continue studying like the lectures that I was studying. You know what I mean? I love yapping about medicine. I'm Angela Ziegler from Overwatch. I'm glad that you're learning. This is amazing. Oh, I'm actually in biomedical science right now. That's great. What are you aspiring to be? Okay, let's go back to the topic while I wait for your responses in chat, silly people. Okay, so the males are more predisposed to all of these cancers most of the time, more than females. Usually the cancers are seen between 60 to 70 years old. 6-7, of course. Adenocarcinoma is most common at 70%. It's like the commonest one. A doctor though, because of my high school's conditions, I couldn't go immediately to a medical track, so I have to do STEM first in medicine. Oh! Oh my god! You can do it! I believe in you! Oh my god, that's actually so cool. You know, it is very cool. I'm proud of you. It's possible. Do not give up. Because luckily for me, I managed to just get into medicine instantly. My brother was, I think, like the medical tract. My brother wants to be a dentist though. My little brother. My younger sister, oh my god, we're being rated. Nice. Oh my god, thank you so much for the raid and welcome to today's stream. Hello, raiders. Hi, hi. How are you doing? Thank you so much for being here. How is your just chatting, dear? Do you have fun today? If you guys don't know, I'm Lokileen. I'm your one and only angel VTuber who's currently in the form of a bunny because people found it very funny to hear that a bunny is teaching you guys about cancers. Today we are talking about other stuff I'm studying and preparing for, like my general surgery quiz. So the stream has been very fun. If you're tired of your stream, please get some rest. But how is your stream, Wolfric? Basically, by the way, just to recap to you guys, we're basically studying esophageal cancers. Hi, I'm studying medicine, so if you guys, like doctors, I'm doctor. Not a doctor yet, but soon to be. Give me like a few months. Ooh, that sounds so cozy. Aww. Oh my god, that is so cute. That's so cute. I'm glad that you managed to tell. Feel free if you to like stick around if you wanna hear me up about like adenocarcinoma and other stuff. I love yapping about medicine. I'm Angela Ziegler Overwatch. Okay, let's continue. Where did we stop? So adenocarcinoma is the most common one, but in Asian countries, it's usually squamous cell carcinoma. Okay, guys? Yes, get comfy, king. Or queen. Or your highness. We're very inclusive here. Anyway, so squamous cell carcinoma is the most common one in Asian countries. Why does it change? What are you talking about? Like, are you talking about Barrett's esophagus, Shoto? What are you talking about? Okay, so, Shoto, what are you asking? Are you talking about like it being like more common? Because, yes. Because, oh god. Also, I had it. Oh yeah, it's because of the diet. Yes. It's because they consume salty and spicy diet. Umami, like if I remember, monosodium. Like I consulted an ENT consultant about this. Who gave me a lecture. This is according to him, but I've not seen any study. I need to see this. Hold on. Let's go to Google Scholar. I need to see this. I need to see if there's like... Wait, no, we need to go PubMed. Monosodium glutamate. Monosodium glutamate. Hold on, guys. Give me a sec. Okay, so what are you taking, Javi? I know it's PPI, but which one are you taking? There's something called omeprazole, I think pantoprazole. But usually, for me, when it was with my GERD, my esomeprazole was more, it was more effective. But that's just me. Okay, let's read this. PubMed, wait, let's see. Monosodium glutamate plus esophageal cancer. I need to see if there are studies. Well, like in general, I vote for Brazil, but Kreml's works just fine. Let's see what Kreml does. Oh, okay, so it's an anti-acid. Okay, excellent, excellent. Anti-acid. Yeah, anti-acid is good because it reduces the acidity. I recommend hydrating a lot because when you're dealing with a very acidic stomach, basically you want to neutralize the acidity. You don't want to drink an alkaline substance. Alkaline stuff will worsen the acidity. Try to consume more water. It will help. Because the water's pH is neutral. And, so you want to balance it out. Emission cancer study. I couldn't find anything. But my consultant told me that there is a big association. Yeah, no, my consultant basically told me that. MSG, like, this is just from what I heard from my consultant. It's, he told me that it is associated with esophageal cancer. So guys, let's continue. Adenocarcinoma is at the bottom because it's at the distal esophagus, okay? And the squamous cell carcinoma is at the top. But yes, this is basically in Asian countries, like think Korea, think Japan, because the salty foods. Salty foods, I think, are definitely associated. That's just me. I'll have to check with the consultant. So let's talk about the symptoms. So what will the person, like the patient, be complaining with? So dysphagia. So it is gradual. It's gradual. Basically, it starts with liquids, like in general. So basically, liquids to then to both solid and liquids. Like difficulty to swallow, difficulty eating. Though there's a condition you guys don't know. It's called achalasia, which is in the other lecture, the esophageal motility disorder one. So achalasia, basically, it's because of the loss of neuronal ganglia. Thank you so much for the sub, Shadow. So, basically, achalasia, it's a neurological issue. And when it comes to that, like, it's because of the loss of the ganglia cells. So there is an issue with the motility of the esophagus. Achalasia in general has both solids and liquids. And it is a predisposer of cancer, by the way, if you guys don't know. Esophageal cancer, by the way. So the patient will come with dysphagia, pain during swallowing, epigastric pain, hoarseness of the voice. Persistent heartburn is a symptom. Yes, it is the epigastric pain, so yes, it is. Like I said, it is because esophageal cancer, GERD, everything causes it. Okay, so you guys, let's talk about why the hoarseness of the voice. Alright, take care, dear. Thank you so much for the raid. I hope you get some rest. So guys, we have something called the recurrent laryngeal nerve, okay? Let's open the picture here. Hi, Uni! This is what I have to study because I'm a doctor. How are you doing, my darling? Let me give you a shout out, dear. I hope you're liking the medical stream so far. Yes, we're studying medicine today from a bunny. Isn't that amazing? So we're talking about why the patients end up coming with hoarseness of voice. So sometimes the masses compress the recurrent laryngeal nerve, which ends up giving you a hoarseness in the voice, once you lose it. Frost, we were talking about you earlier before Siege went to sleep. We were talking about bleeding, and also we spoke a little briefly about hemophilia A. Yeah, we were talking about hemophilia A. Oh, student score. Canned food and eggs. I don't have ramen right now. It's okay. It's okay, my dear. It's okay. I get it. I get it. I'm just privileged that my college isn't expensive. It's like free and they just pay us for being students instead. Will you become my doctor? I'm currently in need of medical attention because I hurt myself pretty badly falling for you. Oh my god! Hello? Don't make me blush. But I can help, don't worry. Yes, Frost. You're the walking exhibit of hemophilia. Hi, Coffee. Yes, we're talking about esophageal cancers right now, Coffee. So we explained the hoarseness of the voice. Upper middle pain. Yes. So I'll give a recap after we're done, okay? Supraclavicular mass, basically above like the chest bone. You know, like the bone that's like not the shoulder bone, the neck. You know, the neck, the bone that's under it. I don't know what to call it in normal terms. I just call it the clavicle, man. Sure. I don't mind being shots, doctor. The voice box? No. It's a neck bone. It's a neck bone. It's like the one that's like the clavicle. The clavicle. Wait. Okay, let's see. Clavicle. Common name. The collarbone. The collarbone. I keep forgetting it's called the collarbone. I'm a doctor, for God's sake. This is so stupid. I'm crying. Listen, our future doctor, guys, yeah. Your doctor is meowing. Stream too much. I'm crying. This is so stupid. I'm your future doctor. You're angry. I'm sobbing. Meow. Yes, what if I'm meowing? God forbid I'm meowing. Can't I have any hobbies? Uh-huh. Stop! Okay, so yes, there's respiratory syndrome because aspiration due to vocal cord involvement. Oh yeah. Okay, so basically the reason there's gonna be respiratory symptoms, it's mainly because like aspiration due to vocal cord involvement or progression of cancer which causes something called tracheoesophageal fistula. Do you guys know what a tracheoesophageal fistula is? Honestly, uni, my dear, I'm still a student. I don't know what type of doctor I'll be because so when doctors graduate, basically I'm getting my own general practitioner degree. Then I have to do 4 years or 5 years for residency. What the hell is a fistula? A fistula is like a hole. It's like basically just a hole between two organs. You know? Like just imagine there's a trachea, like the trachea and the esophagus. Okay? It's just a big hole. Okay, so let's do the grades of the... Let's read this. I will be your patient for everything except the collarbone. You're wild. You guys are allergic to apples. I don't know what type of doctor I'll be, I can't lie. So far it's looking like internal medicine, by the way. Okay guys, let's continue. So we have to talk about the grades of dysplasia. Okay? So grade 1, the patient should be able to swallow most of the food. Grade 2. Swallow soft food. Like, just imagine mashed potatoes. Grade 3. Swallows liquid only. Grade 4. Unable to swallow at all. Even their saliva, by the way. It's very bad. You noticed? I multitask. Lonnie, I'm literally ADHD final boss. I have to like something. I'm sorry, I'm ADHD final boss. Wow. I want to be an ophthalmologist, but the acceptance is so ass. You want to be an ophthalmologist? I am studying! I can multitask! I can multitask! How is the most mid-nap ever? Why'd you cancel your stream? Yeah, no, let's talk about you and the mid-nap of yours. You canceled your stream for a mid-nap. What happened to Shame? Okay, so let's talk about the risk factors for the esophageal cancers. We already spoke about them, so let's just type them out real quickly. So we have dirt, obesity, smoking. H. pylori, by the way, H. pylori, which causes peptic ulcer disease. Frost, do you really want me to do a bimanual and speculum examination on you? Let's just type it. Green, you gotta be nice for Lonnie. Lonnie needs to rest. This is what you're getting for you. You have never gone to an OB/GYN doctor till you experience that. It's uncomfortable, to say the least. Bimanual and speculum. You guys need to look it up. That's your homework. To all the males in chat, look it up. Oh, it's okay, Lonnie. Lonnie, I'm teaching them about the bimanual and speculum examination. They need to see how it's used. They need to imagine how uncomfortable it is. It is uncomfortable. I really feel weird that we as doctors haven't tried to make it more comfortable. No. You're going to jail. Yeah, good, Shadow. Good. Okay, so I have non-steroidal anti-inflammatory drugs because they cause peptic ulcer disease. This is for adenocarcinoma, by the way. Adenocarcinoma. So let's talk about squamous cell carcinoma. Smoking, alcohol, head and neck tumor, HPV. In general, it's mainly not hepatitis, what's it called? Human papilloma virus. Parasitic agent. And the diet. Usually it's because people don't eat vegetables. So always eat your greens, you guys. I love studying. Like, I don't know. They really need to find a way. Like, listen, if it was a man's thing, they would have made it easier. Literally. If it was a man's, like, procedure, they would have found a way to make it comfortable. Except prostate exams. I mean... Yes. Dude, I blame green mangoes for my acid reflux. Honestly, mangoes are good. I love mangoes. So guys, how do we stage esophageal cancer? Okay, let's stage esophageal cancer. So esophageal cancer We have the tumor lymph node factor. Like we said, we always use it. Okay, so esophageal carcinoma is 0 to 4A. This is a esophageal adenocarcinoma. Esophageal squamous carcinoma is to 4B, 0 to 4B. I always eat too much. I get it. So like I said, HRT. Wait, not HRT. What is HRT? Wait, that was. Oh my god, that's for like the hepatic adenoma. Oh, not the HRT. Okay, we stopped at liver stage 4. Okay, so what type of investigations we as doctors are gonna order? Sorry guys, my brain sometimes like shuts down, and I just imagine many things at once. So let's talk about many topics, okay? So the investigations, you guys don't know them, but CBC, urea electrolytes, liver function test, kidney function test, barium swallow, chest x-ray, endoscopy, biopsy, esophageal ultrasound. I'm just remembering them. Chest CT, abdomen, pelvis. Okay, let's see. You're what? What is wrong with you? So yes, guys. So basically, I think these two, the ones I put were unnecessary, but I just monitor like human functions. We can just start with like complete blood count to see like any abnormal changes. So yes, let's talk about it. And then like we can go for an MRI. So it depends. Not all say like the real question we want to ask is, do all patients need surgery? Not really. Yes, it's like yes and no. It's like a yes and no question. It depends on the level or the location of the tumor, the stage of the presentation, proximity to the cricopharynx, or the patient's physical status. Or, like if they're able to tolerate a surgery, because surgeries are big things, and the recovery process is really rough. Okay? Okay, my loves? So it just depends on the patient. Like if it's an early tumor, we can do a resection and just get it over with. So there is something called Seward classification of gastroesophageal tumors for adenocarcinoma. Okay, Seward. Okay, Seward classification gastric cancer. Okay, let's open the tumor. Not the tumor. I mean, let's open the picture. Ugh, it downloaded. Ah! Okay, Cookies. Is there ever a chance to lose your voice? Well, your voice is going to be hoarse because your recurrent laryngeal nerve is compressed. Okay? Like, because, like, that would technically count as losing your voice. You're just gonna sound very hoarse. You're gonna be like, hey, I'm Coffee. You know? It's gonna be really hoarse. It's mainly because once the recurrent laryngeal nerve is compressed, you just end up being hoarse. And there are conditions, for example, where, like, for example, in thyroid removal surgeries, where the recurrent laryngeal nerve gets cut, and the patient ends up just dealing with a complication in process. So as you can see, guys, Type 1, type 2, type 3. Type 1 is in the distal. Wait. Distal esophagus, yes, distal esophagus. With the tumor, center location is like 1 to 5 centimeter above, like the tumor is just here. Once it's not compressed anymore, yes. Yes. Once the tumor is handled, your voice can go back to normal, I think. Don't take my word for this, I don't know, I'm not a surgeon. I'm a student. Okay, gastric cardia with tumor center with 1. Okay, so this one is under. Like, this is literally under the gastric junction. So type 3 is below the anatomical gastroesophageal junction. And it's 2 to 5. Okay. So this is Seward's criteria. Yes, it is. Medicine is just interesting. Oh my god. If you guys are up for it, we can talk about breast cancer tomorrow. If you guys want. Because one of my lectures are actually breast cancer. And it's very educational. If you guys are interested, of course. I need to hydrate. Talking too much makes my throat so dry. Yes, breast cancer is like a really good, interesting topic. So if you guys want. Because I found streaming as a good way to like balance my studies. Just give me a sec, let me just pull up a summary picture. Hold on. Okay, so we are going to go to like the treatment for esophageal cancers. Okay? Treatment of esophageal cancer. Okay, so if it's tumor in situ, T1A superficial, T1B with no lymph node. Oh my god. Wait, this is like the third raid. Oh my god. Hello, raiders, and welcome to today's stream. Thank you so much for joining Alias and to the raid. I am so grateful for you guys to be here. Hello, raiders. Let me give you a shout out. I'm a bunny. How is your stream, my darling? Do you have fun in your stream, Alias? Oh my god, how is Marvel Rifles? If you guys don't know, I'm Mokamin, I'm your one and only angel VTuber, who's also a sad medical school student suffering while becoming a doctor quite soon. I'm currently doing my best because I'm simply preparing for a quiz coming soon. And we're talking about esophageal cancers, which are cancers that are located in the esophagus. So you guys just joined at the treatment part. If you're tired after your stream, do not hesitate to get some rest. Oh god! Oh no! 5 in a row! Lost. Thank you, Green. That's what I'm planning on doing. You guys are so sweet. Thank you, guys. So we're talking about the management right now. So the TX means treatment for esophagus. So we can do it with endoscopic removal because it's not invasive. We don't want to, as doctors and surgeons, we do not want to invade. But if you guys want to rest after the stream, do not hesitate to get your after stream care, get your food, get your water, get everything. Thank you! I find it really funny that I'm just a bunny talking about cancers in general. Oh, it's so stupid. It's actually quite stupid. Okay, let's see what lectures I did so far. Give me a sec, you guys. Okay, so we didn't do the motility disorders. We already did the liver cancers. Okay. We did GERD. And neoplasms of the esophagus. We did this. We did this. So we have bariatric surgery, thoracic emergencies, mediastinal diseases. Then we have breast tomorrow. We're gonna do breast tomorrow. We have gallbladder and biliary diseases. Okay, guys. So tomorrow, I wasn't supposed to stream, but I am planning on streaming instead. So you guys, tomorrow, so I'm gonna try to organize stuff for today. I'm going to need to divide the stream between today and tomorrow. And Saturday will be a collab before I can see if my dad takes my PC for the repairs. Okay, you guys? So let's see. We already did... We technically are done with this one, so it's 4 lectures. Okay, so we might end up doing... Okay, let's see how many lectures we have. 1, 2, 3, 4, 5, 6, 7, 10, 11, 12, 13. Thank you. I mean, there's stuff that I studied. Yes, yes. I'm listening to Not Cry soundtracks right now. Oh my god. Wait, let's just put Poor Dormis because yes. This is gonna be you guys are gonna notice it's the raid music, okay? Hey? Oh my god, thank you so much for becoming a divine seraph and Viva Nexus. And I hope you enjoy your stay here. I'm currently handling esophageal cancers and management while balancing which lectures I'm gonna plan on finishing today. Because it's gonna be a long stream, you know? I might stream for another hour extra, just depending on the lecture in general. I feel like bariatric surgery is an interesting topic to talk about today. And motility. So we'll do motility disorders and bariatric surgery. And then we might play some games or go to sleep. Okay? So yes, you guys are learning wisdom from the bunny. Alright, so let's continue. When it comes to the management for basically esophageal cancer, depends on the staging. Tumor in situ, 2E1A, as long as the lymph nodes are not involved. Oh, wait. Oh no, why did I put this here? So basically we can do endoscopic removal. Or we can just remove the whole esophagus. Okay? But let's make it more visible so you guys can see. I hope you guys are able to see, okay? Esophagectomy means we remove the entire esophagus. Okay, but it's still... Wait, this loop is kind of buns. Okay, let's see, we need a better loop. Okay, let's see, it's this one. No, we want to go with this one. Alright, Poogies, look in. Alright, so next tumor is early but deeper. Think T1B. Okay, T1B. We remove it via esophagectomy. The earlier we find the tumor, the easier for us to remove it. Okay? Because the risk is higher for the spread. There's a higher chance for it to spread, okay? So that is it in general. And then we have locally advanced. So we basically can divide it to high risk or low risk, okay? So if we have T1B to T2, this is basically tumor classification stuff. We just continue with the esophagectomy too. This is only in low risk patients. Low risk. It changes if it's high risk or stuff, okay? So if it's high risk, for example, think high risk, which is T2 and lymph node involvement, we have to do chemo. We have to do chemo. Chemotherapy plus surgery. It's either neoadjuvant chemo, or we can just continue with pre-op chemo. If the patient refuses surgery, then we have to do chemo only. Okay? Because we want to shrink first, then operate. Very advanced is chemo because it's metastatic. It's just spreading everywhere. The cancer is everywhere. So we can't do the surgery, unfortunately. It only has to be chemo. They live, they live. They die, they die. We can't do much about it. It's really bad. It's really bad. Like how tough cancer can be. But yes. It just depends on the stage in general. Wait, I want to put this here. I like this one. Okay. Next topic. Actually, not topic. Not next topic. We're not even done yet. Are we? Yeah, we're not done yet. So like I said, the tumor is just depending on that. Like, T4B is only chemotherapy. Because lymph nodes are everywhere, yes. The cancer spreads through lymph nodes, actually. Okay? And there are surgical staging after, like, the tumor. Like, if you remove the tumor entirely, it's gonna be R0. Hold on, let's see. Tumor is completely cut out. With no tumor cells. Like, no, like you just basically cut the entire tumor out. And there are no remains. Because after you cut out the tumor, you want to send a biopsy from the surrounding region, right? And that means that the tumor is gone. Okay? R1 is basically there's a little distance of less than 1 millimeter. There is macroscopic residual tumor, like Spectral! Dude, I was waiting for you! Hi, Spectral! Spectral, we were talking about esophageal cancers. I'm preparing for my quiz! Dude, let me give Spectral a shout out. Hi, Spectral! I'm so happy you made it! Oh my god, you missed out. We spoke about benign liver masses, GERD, malignant liver lesions, and we're currently finishing esophageal tumors. Okay, Spectral. Spectral, can you tell me why squamous cell carcinoma is more common in Asian countries? You're a doctor. You need to answer. Chop chop. You must answer. You're a doctor. You need to know. Why is squamous cell carcinoma? Actually, it's mainly because, like, the diet there. Apparently, Spectral, I found it really weird, but I didn't find any research involving MSG and esophageal cancer. But my ENT consultant said that there's a correlation between cancers. Like, why? I feel like there is an association with it. Because my consultant told me. Like, he was an ENT consultant. He was, like, really old, though. He said there was an association. I'm not sure. But I didn't find any research. Spectral, can you help me find any research? Yeah, I know. There aren't really any studies about it. Smoking in general increases the risk of esophagus, and yeah, smoking does give esophageal carcinoma. I don't know what's better. Okay, so we already spoke about post-resection. So if it's R0, we can just continue surveillance. We start with surveillance if we have nothing remaining. Surveillance or chemoradiation. Oh my god, coffee. What do you think that Sumer is inspired by our cultures combined? Because, you know, you're Desi, I'm the other side. Hi Riff Raff, how are you doing? I don't know what betel leaf is, I've never heard of it. But no, leafy stuff helps you. Like, it's like if you eat more greens, then. Oh, yeah, no, that is. Anything that's toxic is bad for you. But look, I love Sumeru so much. I love Sumeru from Genshin. Okay, back to the topics. So, surveillance or chemo? For T2, if like, you know, if the tumor is still there, but it's like T2. Even though lymph nodes aren't there. If the lymph... Wait. T3 to T4A and no lymph node spread is basically just surveillance chemo radiation or chemo... It's just chemo radiation. It's just chemo. Ignore how messy my notes are, Spectral. Ignore how messy they are. It's like a shooting rifle thing, and that has betel nut in it. Yeah, oh god, just avoid it at all costs. Ooh, avoid it. R1 is chemo. R2 is chemo or palliative, because you can't do much about it. Oh my god, Coffee, what do you think about Sumeru? Because, you know, Sumeru is mixed between my culture and your cultures. Yes. Sumeru from Genshin Impact. Oh, thank you. Thank you for the link, Spectral. Because, you know, Sumeru has, like, multiple cultures aesthetic. Loki Coffee, you and I would be from Sumeru. I can already imagine myself in, like, the Amurta, like, academy. Like, I would just be there. I'd be a student there. The Amurta Darshan. Okay, so what type of face effect deck do we have? Okay. Yeah, I love how they took like the cool parts of our cultures. Oh my god, they added shawarma there. I was so happy. I was like, wow, they had my favorite food there. Amazing. Do you find your favorite food there too? Also, Nahida's dessert is actually like something my mom likes to eat. I'm just surprised you didn't add falafels. Thank you so much for the gifted sub, Riff Raff. I hope you enjoy your ad-free experience, by the way, Coffee. Alright, let's talk about specific types. We have open or minimally invasive. So we have many approaches. Transhiatal, which is opening, like it's through the abdomen. I don't know what's Ivor Lewis. Let's take a look at Ivor Lewis. So let's take a look at Ivor Lewis. We basically cut from here. Oh, the B is Ivor Lewis. Oh. Wait, let's see, hold on. So this is Ivor Lewis, you see? We just cut through here. Or we can just make 3 holes. One is in the chest, abdomen, neck. Left thoracoabdominal and anastomosis level. Interesting. Spectral, are you here? Do you want to be a jazz together? Let's be general surgery. You should get there, Coffee. You should. You need to experience Sumeru. Listen, Sumeru is worth it. Sumeru is very good. Like, it's really nice that they took, like, cultures and stuff. Oh my god, Coffee. Isn't Ruka Devata like an Indian name in general? Like, it's like a god thing? I'm not sure. Let's see. Ruka Devata. Who is it inspired by? Okay, it's inspired by South Asian, Hindu, and Buddhist terminology. Sanskrit, Pali, tree or plant having to do with plants. Yeah, that's what I meant! Oh! Yeah, it's interesting. Hi Cloud, welcome to today's stream. We just went through like Genshin ADHD autism moment. Because I just decided to shift topics. But it's really cool. Okay. Okay, so let's just look in. We're almost done with this lecture. So we already looked at the types of esophagectomies. We can replace the esophagus with the stomach. So we can just replace it with the stomach or colon or jejunum. The right, and then we can just use the right gastroepiploic artery and the right gastric artery, so we can just as like the blood supplies. Post-op complications, there's a lot of things. Let's see. Post-op complications are pneumonia, aspiration pneumonia, respiratory failure. There might be a leak. AFib necrosis. Oh god, this is scary. Well, yes. Well, yes. I'm just really glad you guys are enjoying the lectures. And late part is anastomotic stricture, reflex esophagitis, delayed emptying. Oh my god, we finished so many lectures today. Let me just put a checklist on the one that I finished. Okay, let's just put the check mark here. Oh my god, my brain is like so fried. So we did GERD already, we did esophageal tumors already. Oh damn, we did like 4 lectures today. That's like 2 days worth of lectures, or maybe 3 days. Interesting. Okay. Okay, we're gonna do bariatric surgery because it... Oh no, bariatric surgery is really long. I don't have the energy for bariatric surgery. Like, yeah, I'm feeling very productive because I learned it from Spectral. Spectral was like, Mocha, why don't you stream your studying sessions? I was like, I don't focus, but like, when you guys give me the chance to, I actually focus. Like, you guys are so interactive with me, especially about like the topics. This motivates me to like, want to help you guys learn more about what I'm learning. You know? Nice. Okay. Okay, we need to see a shorter lecture that wouldn't be a pain in the bum. Okay, I think esophageal motility disorder is a really good lecture. So let's talk about the Yes, basically it just makes me speak French for a little. No, it's just stretching, don't worry. I was feeling very stiff, you know? So, it just makes me speak French while French background music plays. It's interesting. I'm really glad. So we're gonna talk about... Wait, 1, 2, 3, 4... Oh my god, this is gonna be the 5th one. Esophageal motility disorders. Okay. I love the Samara battle music. Oh my god. Hold on. I think she also wears a Mr. Stoosh. Well. Wait. I have a perfect theme to play after this. Bro, yo, can I just say something? Coffee, just imagine you're like Sumeru and like you find an NPC with your name. Like just imagine. Because that's what happened. I had an NPC that had my dad's name. Like my name is not really common. But like I had an NPC that had my dad's name. I was like, what? Wow. Okay, so we have like my whole bloodline here now. I'm in Genshin, y'all. No, like actually. Just imagine. Just go around Sumeru, explore, and you're gonna like find like NPCs with your name. Somehow. Like, literally. Hi, Uni. Yes, you're up here. It's okay. There is a chance. Oh my god. I got distracted with the Genshin talk. Yes, Uni, you're with me. Meow. Okay, so we already spoke about the esophagus, right? So, esophageal disorders are basically disorders that affect the motor function, which affects the peristalsis. So you know peristalsis, right? Let's I need to show you guys what the GIF is for peristalsis, okay? So guys, we're gonna open this and we're gonna show it to you so you guys figure out how peristalsis works. Peristalsis is a process by which your food just goes to your stomach. Like, look at this. This is your throat, right? Esophagus. You go down. Bum 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 bum. Bum 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 bum. Bum 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 bum. Bum 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 bum. It goes down. Okay? So you see, this is peristalsis. So esophageal motility disorders are disorders by which that is affected. Yes. It's like contractions. It's basically contractions. It's like a literal elevator. That's a good analogy, yes. It's like a slimy thing is just walking through. Okay? So it's basically that. Okay, we will continue now with the topic. This is basically it. So it's just characterized by the impact on the motility and the lower esophageal sphincter, which is basically the door to the stomach. How is it clinically relevant? So its clinical relevance is that it's the common cause of difficulty in swallowing and chest pain. Okay, so you guys are gonna learn a lot today. And one day you guys are gonna meet someone who has achalasia. And you guys are gonna be like, oh my god, Mocha, I met someone who has achalasia. This random bunny VTuber taught me about achalasia. Wow! Isn't that so cool? And I'll be like, yes, it is very cool. Yeah. Take your time. What's up? What's up, Green? By the way, this is one of my favorite boss fight themes. I really love the sitar as a musical instrument. Me, I'm the bunny VTuber. I'm the angel. the stupid bunny PNG just telling you guys about cancers and motility disorders. Okay, so what are the conditions that we're gonna talk about? We're gonna talk about primary versus secondary. So primary is like, it's the main cause. It's something happened, like achalasia, diffuse esophageal spasm, and hypercontractile esophagus. Hypercontractile like means that the contractions are strong, okay? No, like the suitor is really nice. Oh yeah, you're talking about Museum. Yes. My god, I love this boss fight. Oh my god. Oh my god, y'all, if you guys ever wonder what this boss fight is, it's called God Devouring Mania. It's a really good song. I would recommend you guys listen to it. It's my favorite. Wait, let's listen to Dotaries next. Dotaries is a good boss theme. Okay, so this is the primary ones. Secondary are usually caused by other diseases like scleroderma, Chagas disease, or diabetes. What the heck is a scleroderma? I need to revisit. It's an autoimmune disease. Oh! Okay, okay, okay. Mm-hmm. Okay, let's put Dotary's theme because I hate Dotary, but the theme is really good. Okay, y'all. Alright, y'all, we're locking in. So scleroderma, diabetes, and that. Yes? So how do patients tend to present? Oh, well, it's basically an autoimmune disease, by which, it's basically excess collagen. It's an autoimmune disease. Your body attacks itself. Like damage, like it injures its internal organs, blood vessels, and joints. It has renal, it's phenomenal. Yes, that's why collagen production. But we can't treat the symptoms. Yeah, autoimmune diseases are always rough. Like, I always feel bad for like the girls who have like systematic lupus erythematosus, which is SLE, which is
The woman was too stunned to speak.
Hi, I'm back. I'm back. I'm back. I'm back. I'm back. Hi, hi. We can lock in. Alright, Pookies, let's go. Let's go, let's go. Wait. Ooh. So... Wait, I look, I love the theme. The theme in like the boss fight is very awesome. Hi, hi. The doctor is finally back. The doctor is ready to take care of you. Okay, guys. So let's talk about the other topics. So, how will the patient present? Difficulty swallowing. Difficulty swallowing. It's gonna be bad in both. In difficulty swallowing, but like liquids or hot like foods. But Achilles has both. Hi, Haru. Hello, my darling. You're hearing me talk about esophageal motility disorders because I'm a doctor and I have to study. How are you doing? So the patient will have difficulty swallowing. Achalasia has both foods and liquids. The food will flow back up because regurgitation. How do you sleep? Ew, I'm a bunny! I'm a bunny! I'm a bunny! I'm not a cat, I'm a bunny! I'm a bunny! I'm a bunny! No! No! I'm a bunny! I'm a bunny! I'm a bunny! I'm a bunny! Stop! I'm a bunny! No! 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 Okay, so the food will flow back up, which is regurgitation. Chest pain, mainly, it's gonna be like very bad in like the diffused esophageal spasm. It's gonna be very bad in this one. This is like the pain, the thing that people present with. They're just gonna present with diffuse esophageal spasm. You're so mean! I'm gonna touch you! And not in a nice way. More like evil mean way, you know? Okay, so heartburn. Yeah, you can't do much. I'm very ominous. Okay, we have weight loss, which is gonna cause nocturnal cough. We already classified. Hold on, let's put this. No. No. Okay, so let's talk about achalasia. Okay. So basically the esophageal sphincter, the LES, fails to relax and it results in like the loss in peristalsis. So basically the food is gonna have a hard time going down. Like, you missed out. I was showing chat earlier what peristalsis was. So yes, basically that. Loss of peristaltic movements. It's mainly caused because there's loss of postganglionic inhibitory neurons in Arbac myenteric plexus. I sound like I'm cursing you guys in Latin, but yes, basically TLDR by loss of ganglion neuron cells. Okay. So because of that, yes, my furniture started floating. That was a plan. See, I told you, you do not want to mess with me. So diffuse esophageal spasm. Basically, it's like people dancing, but not in rhythm, okay? Like, just think of everything being unorganized. Diffuse esophageal spasm, basically, the peristalsis is unorganized and uncoordinated. No! This is revenge. Wait, let's put a different theme. Wait, I like this theme, so I'm gonna put a different theme right now. Like, hold on. I like this one, hold on. Nocturne. Okay, this is very nice. This fits the vibe. Hello guys, I am Sensei Mocha. I am teaching you guys about esophageal motility disorders. Meow. So yes, so diffuse esophageal spasm, basically the movement of like the food and in general, like everything in like the esophagus is uncoordinated and unorganized. It's caused by impaired inhibitory innervation of the body of the esophagus. TLDR, basically, there's inhibition, right? Inhibitory nerves, which are the things that stop it, basically are dysfunctional. Like they're impaired, okay? So this is what you have to do. Jackhammer esophagus is very contractile, like it's contractile. Jackhammer esophagus is like very, very, very strong contractions. Basically, the nerves are too excited. Okay, guys, I'm sorry, I'm trying to dumb it down because if you like low-key, if you guys saw like what I'm reading, you guys would get migraines. Oh, hi Nature, welcome to the stream, my darling. Let me give you a shout out, dear. Thank you so much for being here. I don't know if I gave you a shout out at the beginning of the stream, but I forgot. Hi Vesvalod, welcome to today's stream. Thank you so much for the hydrate, by the way, Nature. We're having a good day. The setting has been amazing. Okay, so let's talk more about that. So this is a primary. These are like the primary causes. So this is achalasia. Now we go to the secondary, scleroderma esophagus. So basically in the scleroderma esophagus, the muscles become atrophic. By atrophy, atrophy is basically like just wasted. Like the muscles are wasted because of that. So the muscles become wasted and everything becomes weaker. Weak everything. Okay, so basically it's an infection by a thing called Trypanosoma cruzi. Hara, if you're here, your name is Trypanosoma cruzi. Okay, so yes, Trypanosoma cruzi. That is a pathogen that basically destroys the mesenteric plexus, which gives symptoms of achalasia. Okay. Okay, so we have something called, oh wait, that's diabetes. Okay, diabetes mellitus. It just causes autonomic neuropathy, which basically destroys the peristalsis. So what would the patients complain about? So achalasia is progressive. It's both. Progressive difficulty in both. Like, hold on. Symptoms. In both solid and liquid. Chest pain plus regurgitation and weight loss. And it also leads to like risk of esophageal cancer, by the way, if you guys don't know. And then we have diffuse esophageal spasm, which is low-key intermittent dysphagia, which is like, oh my god, in swallowing. Hold on. So it's basically intermittent, but yes. But the thing that differentiates diffuse esophageal spasm with everyone, it's very severe pain. And it's triggered by stress or cold liquids. Scleroderma basically has a hard time with solids because think of it, it's wasted. Severe regurgitation plus symptoms of GERD. So how do we diagnose? Let's start with the how to diagnose. We start with endoscopy because we want to rule out the structural cause. What is your new clip? Anyways, so guys, we have endoscopy, right? We have endoscopy because we want to rule out to rule out structural cause. We have barium swallow to see how everything functions. And honestly, the golden standard, guys, always remember high resolution manometry. Because it helps us check the motility. We have to remember. It's on voice meter diet, of course. Of course. Okay. So we basically explained everything. So what are the findings? Barium swallow. In achalasia, achalasia has bird beak sign. Diffuse esophageal spasm, corkscrew, or rosary bead. Scleroderma is dilated esophagus. Let me show you guys. Let's pull up the pictures. Okay, let's go to open like the lecture right now. Radiopedia, bird beak. I really hope that Radiopedia has it. Oh, they do have it. Okay, guys. Okay, guys, so this is basically the sign of Achalasia. Look at this. So what you guys are seeing, this is a bird beak sign. This is it. It's characteristic of Achalasia. Okay, this is clear. You guys can notice it here. Do you notice how it looks like a bird's beak? Corkscrew. Yeah, because there are signs. So this is, as you can see, wait. Ooh, wait, this is so cool. Okay, so this is a corkscrew sign, okay? This is what you see in diffuse esophageal spasm. So this is a corkscrew sign. Can you see how it's like twisting? This is a corkscrew sign. Hi, Solunek. Welcome to today's stream. How are you doing? Ugh, no fire. Lame. Yeah, you missed out on several lectures, but that's fine. I forgive you. So yes. Oh my god, I can't believe I've been streaming for like 4 hours. Damn, I did a lot today. I'm proud of myself. Okay. So scleroderma's dilated esophagus. You guys saw it? Achalasia has absence, peristalsis. Scleroderma has... Ugh, my brain is so dead. It's okay, don't worry. I'm just joking around. I'm acting like one of my professors. Oh, ha, ha. You do not wish to mess with me. Dude, I low-key need to get an emote of myself doing that note thing. Okay, I'm like, honestly, I'm just gonna finish this lecture and I might call it a day here. Because I can't lie. Yeah, I haven't stopped really. I've been studying for the past 4 hours. Yes. I've been looking in and my brain is a little bit of a shutdown right now. I'm just gonna push and then rest, because my brain is really dead. We managed to finish like 1, 2, 3, 4, and now we're on our fixed lecture. So we talked about scleroderma. Okay. So we already figured out how esophageal manometry looks. So achalasia, basically, very tense lower esophageal sphincter. Like all of them are like, wait, let's just put this. Very active and not resting. Diffuse esophageal spasm, normal. Scleroderma, not active. Okay, peristalsis wise, achalasia is gonna have, hold on. Wait, you can actually insert a table. Wait, that's actually cool. What? Okay, this is really good. This is really good. Wait, this is easy. This is easy now. Okay, we can do it. Okay, so you guys can see this, okay? Achalasia diffuses esophageal sphincter spasm. Extremely active LES, normal LES, and not active LES. Okay, this is how you remember it. Okay. So let's talk about the peristalsis, the movement. So achalasia, basically loss of ganglion. So it's gonna be absent. Extremely contractile. Hold on. Contractile with high amplitudes, weak or absent. So how do you find it? Like, what are like the special findings? Type 1 to 2. Chicago classification. And 20% premature contractions, we already spoke about it. It's basically very contractile. And this one is hypotensive peristalsis. Okay, so we basically discussed like the manometry findings. This is a manometry findings, by the way. Okay, what else? So what are our goals? We have several approaches where we can handle this condition. These conditions, I mean. We have medical, endoscopic, and surgical, okay? Of course, everything is just always, we start with medical. So for achalasia, we usually start with nitrates, but it gives limited relief. We can honestly, like, the most definitive management for achalasia is surgery, because the other stuff just are bad for it in general. Because we have botulism toxin. It's for people who cannot afford to deal with surgery. Like, think old people, okay? They would die if we took them to the OR. Oh my god, I kind of feel like my brain actually shutting down. Sorry, I'm a little brain dead. I'm locked in, Okay. No, we're almost done there. Okay, so like we said, Heller myotomy, like, hold on, for people who can deal with surgery, definitive management is Heller myotomy, but we can start with something called POEM. I can't. I need to finish this lecture. The diffuse esophageal spasm treatment, like we said. Oh no, medical. Okay, DS treatment is calcium channel. Calcium channel blockers. But ideally, it's just ideally long myotomy. Well, yes, I'm free. Last thing we need to know is scleral derma is just live modifications and PPIs. Okay, guys, I'm sorry, guys. My brain is very, very brain dead right now. I can't really go on right now. It's like 3 hours. Like, it's so funny that I'm gonna end at 3 a.m., but I hope you guys enjoyed. And we can continue tomorrow if you guys are interested in like studying with me, because studying in general has actually helped me so much, by the way. I hope like the topics we talked about, you guys will be able to handle them if you guys end up dealing with them in your daily lives. Tomorrow we have 5 more lectures and they should be easy. And if you guys are interested in learning about breast cancer, do tune in tomorrow's stream. Then I'll see you guys, okay? I love you guys. Good night, everyone.